and our moderators. Now over to you, Dr. Kaul. You may start.
Yeah, thank you. Good morning. Welcome to this day 3 session. There is a slight modification. We are not going live to these 2 live transmissions because there is some delay. And we would start with the presentation by Dr. Ritvik. It is Fortis Escort's experience with robotic cardiac cases with Mantra. Let's have him first.
Thank you. Good morning, Dr. Kaul, Dr. Hiramat, and respected dignitaries. I welcome you to the morning session, and it's not my experience at Fortis Escorts. It's all the difficulties and the pain and the amount of time we devoted to develop the program very humbly at Fortis Escorts. So it's basically our experience of learning curve, how we overcome the learning curve, especially in coronary artery bypass grafting surgery using SSi Mantra 3.0 system at Fortis Escorts. With this, I would like to introduce myself. I'm in charge of the minimally invasive and robotic cardiac surgery program at Fortis Escorts. And so, as we all know that in robotic assisted cardiac bypass, we usually harvest the mammary or bilateral mammaries and then do a mini thoracotomy, and then we go for the bypass, or we can be totally endoscopic, that is TCAP, and hybrid revascularization. So in our hospital, we have only done the mini thoracotomy and robotic assisted lima and bilateral mammary harvest and couple of hybrid revascularization with single graft, but we have not done TCAP till now. There are 2 systems available. One is Da Vinci and one is the SSi Mantra. Presently, we are using the SSi Mantra system in our hospital. Although, historically, our hospital has the first Da Vinci system in the country. So, these are 2 devices available in our country at present to do cardiac operations. One is the open system, as we tell it, that is the Mantra system, where the console is open. And the other one is the Da Vinci system, and the console is closed or semi-closed. So, why robotic CABG is again the same slide. I'm not going, but definitely what I found it very difficult to start is that learning curve is extremely steep in any kind of robotic, especially cardiac procedures. It's highly dependent on the team. Even if you change the team members in day-to-day basis, it's not going to be successful. The operating time is extremely very long and prolonged in the initial couple of cases, and the capital cost is definitely high, and we cannot select all the cases for robotic cardiac surgery. Especially last point is very important, conversion risk, because where you are having like 10 cases a day, where 8 to 9 cases are done openly, and you do 1 robotic case and that get converted, so the program gets a big pause. So those are very small, very important aspects which we must all understand. And it is very easy to do a single surgeon and a single institute robotic cardiac surgery. But having said that, I would like to emphasize that where there are 10 theaters and we are doing 20 cases a day, it is very difficult to start alone in that kind of milieu and ecosystem. So our curve was very painful, but it gets slower in the last couple of months' time. It is very steep, manageable. It requires a structured approach to ensure patient safety while gaining the proficiency. It is multidimensional, that it also needs consult surgeons' technical skills, and the organization must support you in building up the entire team. So, to understand the learning curve, we found that literature have suggested that you should do at least 15 to 25 cases of lima harvest, and then the next 30 to 50 cases for operative time optimization, and then 50 cases to have the full program maturity. These are the optics or matrices, and these are the case selections which we followed in our institute. That in the first 50 cases, definitely good targets, small hearts, although these are very imaginary pictures I am showing, we don't get this kind of cases anywhere nowadays. But having said that, relatively we should have good targets and pure single vessel diseases to start with lymphedema, good ventricular function, non-calcified aorta, and the first 50 to 100 cases. As of now, we are doing all triple vessel diseases with different types of ventricular functions, also with bigger hearts and moderate LV dysfunction. And after 100 cases, which I have not gone till now, but you can do in a lot of cases where patients are good candidates for CAVG. There are the phases of learning curve again, and initiation phase, consultation phase, and mastery phase. So initiation phase is very important, that you have long operating time, the cognitive load is very high on you, patient selection should be extremely strict, and then in the consultation phase, now we are at this consultation, between the consultation and the mastery phase, where we have optimized, standardized our port placements, our efficiency have become better, our harvest time has become definitely much better now. As you can see in my today's case in the afternoon, I will go to see the bilateral memory harvest. And these are the key determinants to success. I would definitely say that here SSi as an organization have really supported in our hospital to build up the cardiac program very robustly. So institution plus the organization from the robotic company is extremely important, along with the structured training program, and most importantly our team, especially the anesthesia familiarity with single lung ventilation is good. So this is our institutional experience. This experience has been quoted till December 2025, and after that we have done about another 30 cases which I have not shared in this particular presentation, because I have picked up the numbers from the system. So this is our operating room where we keep the robo. It's a big theater where you can in fact keep two systems of SSi. This is the standard robotic arms of an SSi system. And program initiation we started with the Sudhir Srivastava in 2024 on the day of Dhanteres in October. And then till December 2025, we have completed 108 cases. In the team, we have the lead surgeon is me, and there are 2 assistant surgeons. Then we have got 3 dedicated robotic scrub nurses and 2 cardiac anesthesiologists, and one of them have recently joined from Leipzig with us only for assisting minimally invasive cardiac anesthesia. And definitely we have the perfusionists who are dedicated to robotic cardiac program in our intracardiac procedures and as backup in the op-cap bypass surgeries. So these are a preoperative workup standard for any minimally invasive cases. We actually there is not contraindication for robotic assisted CAVG, it's a contraindication for in general minimally invasive cases. Number 1, unable to tolerate single lung ventilation, severe LV dysfunction, very diffusely diseased coronaries, cardiogenic shock, very high PA pressures, calcified aorta, severe chest wall deformity, and severe peripheral vascular disease. We generally avoid this kind of aortas in any kind of mix, especially and also with robotic assisted CAVGs. These are the parts of the robot and instruments, the surgeon console, and these are the class pedals and different parts of the surgical console. It's a very steady and a very ergonomically designed system, and we are extremely comfortable operating with this system for last 2 years, and hope will be a lot of cardiac surgeons are getting more and more acquainted with this system now at present. So this is the system where we work on the it's very easy to, because you can see the atmosphere and you're open, there is no interface between you and the screen. So I think this is one of the biggest advantage of this console, about the ergonomics and the design of the chair and everything, every single piece of the equipment of the surgical console. I have been extremely used to it now, and our speed has really gained in the last 6 months. If you see that initially it took long time in the console, but almost in last I would say about 35-40 cases, our average console time has gone to 50 minutes. In some cases we have done it around 35 minutes, in some cases 45 minutes. If my console time goes up, that means my main the table side assistant is not there on that day, then I can definitely tell you that in that day exchange of instruments and some of the like clip application of clips becomes difficult sometimes. Otherwise, we are hoping that this will come down further to about 35 to 45 minutes in the days to come. We have got two mortalities. One of them had massive GI bleeding post surgery. I don't think it's related to the robo and to the procedure, but definitely it happened within the first 6 hours. And the second patient had severe low cardiac output in the third day and he died. We have got one massive stroke in one patient, but again it's not to the robot, but he has got a lot of calcium in the aorta, and he arrested while I was doing the Lima to LED, and then we have to go emergency on fem bypass, and probably some of the parts of some calcified thing has gone to the brain, and there's a big stroke. There are two re-explorations, 1.8%. We converted 3 patients to sternotomy because of hemodynamic instability. We have got one port-related injury where we used the varus needle, but somehow there's a very small lady, so my port have gone to the right ventricle directly. So when I just saw open the camera, I can see the trabecule inside the right ventricle. So yeah, but that patient survived. We immediately converted to sternotomy and went on pump, and luckily that port didn't go through the LED, and we did a completion CABG through sternotomy, and she survived and went home. But this is a very catastrophic complication. We should be able to avoid that. We revised our graphs in one case where all the graphs failed in the ICU itself, and I don't think that is again because of robo, where we used one memory and 4 veins, but all of them failed because of diffuse disease or whatever, but we revised the grafts, and again this patient also went home successfully. So we have started doing our graft patency, which I will probably present in our journal in the next couple of months, and started doing robust follow-up with them at 6 months to 1 year, and the symptoms, we have definitely seen that they have good symptom improvement, return to work time, and importantly, if you get a good robotic bypass case going back to the society, he brings back more patients to you. So that's what I am getting now, that one robotic case goes back to the society, he is doing well, and he brings back cases, and he promotes also. It is the best promoter of this therapy, I would say. So to standardize, we have standard our port mapping, dedicated robotic chest list, team briefing protocol, dry run before each case, and these are our standard 2nd, 4th, and 6th space or 3rd, 5th, and 7th space port placement for usually the robotic IMA harvest. And we always keep taking help from Dr. Sudhir Srivastava sir for any technical glitches, and he's always kind enough. If he's in the country, he definitely helps us whatever we get. That is the biggest advantage we have, being in good proximity of Dr. Srivastava all the time. And this is our standard equipment organized in our theater. And so case selection strategy, we have to have isolated LED, good ventricular, non-obese, no severe lung disease. And later, at this stage, we are doing multivessel diseases and hybrid revascularization. It's very good that we have some of the cardiologists in our hospital, they believe in hybrid revascularization because they still think that Lima to LED is a very good graft. So only thing is that we do it the same day. We intubate the patient and do the Lima to LED first, and then send them back to the cath lab on ventilator to get the stented done, and then bring them back to the ICU. We have done about 5 cases till now, but they are doing really well. So these are technical pearls. So I think cost consideration is very important in robotic surgeries. So initial investment, if we say that long-term benefits is very high, then it definitely reduces the length of stay impact, increased patient demand, and program is well sustained. So till now, I am very, very happy to say you that if I say somebody that you will need a robotic assisted procedure, bearing 1 or 2 patients probably in the last 2 years, nobody has denied that procedure. And frankly speaking, I was initially thinking that patient will ask me what system you are using, and interestingly, nobody has asked me till now. If you say it is robot, that means a robot. They are not going to ask you which company, which make, which design you are using. So I think it's a very welcome step for all of us to convince patient and ask them for better quality of life and shorter hospital stay in the coming days. So we tried this way, shorter learning curve for surgeons with prior MICS or endoscopic cardiac procedures. To have a brief note, we have done about 600 minimally invasive cases before we started the robotic program. We have got extensive exposure to MICS Lima and Bima takedown before we took the robo. Initial cases we have done without obesity and too much of fat in the chest wall. That has really helped us. Initially we started doing only pedicle IMA, now we have gone to skeletonized IMA. And definitely we initially start to do the efficient dissection of the endothoracic fascia and started having minimal exchange of instruments. So these are the training phases where we have gone through different labs, different countries, and I think these are very important. So the key takeaways from my side would be robotic CABG is very safe and reproducible. Institutional commitment is always determines our success. Learning curve is real, but it is manageable, and outcome improves significantly after 20 to 30 cases. Team consistency is pretty critical. With this, I would like to thank SSi team and Dr. Sudhir Srivastava for giving me the opportunity to work number one on robotic Mantra 3.0 system, help us building our program and giving the chance to expand our program efficiently and very futuristically. Thank you so much.
Thank you, Ritvik, for an excellent presentation. I am really happy because, I was associated with this program, and the gentleman sitting next to me, Dr. Sudhir Srivastava, I think started the program in the country, and Escorts was the first hospital to start a dedicated robotic system and robotic program, and he was the one who started this in our country. I have seen his dedication, and those days we used to discuss that, and he always used to tell me one day we'll design our own mantra, and that is this robotic system. I never believed it at that time. I was telling him I could never believe that he could reach this heights. I was happy to know that this program is going on so well. I have one question for you. Tell me one thing. Have you worked on the other system also?
No, sir, not till now. No.
Huh.
So this is our first system after we, the Da Vinci system got away from Escorts in 2017, yes, sir.
Okay. And suppose somebody wants to start this program, how, mainly the selection of cases, and what should we just start with Lima to LAD as the first case?
Sir, I think nobody should go directly to the robotic Lima to LED or even Lima takedown. I think if we have to really start a robotic program, I think he should be very proficient, he or she should be very proficient in minimally invasive cases, and at least I think around 25 to 30 Lima takedown, because that's also very important how you see the memory from the other side. I think that's a very important optics of the whole memory takedown, because we always see the open cases from the other side. So we have to be very comfortable in seeing the memory from the left side also. And then if they have done that, I think definitely, yes, we can progress. Because initially I was very skeptical on myself that I have never done anything laparoscopically or endoscopically. How can I do that? But after starting with the robotic system, I think it was very easy, and the learning curve got smaller and smaller and very easier.
Yeah, why I was asking you, because we cardiac surgeons have no experience in endoscopic surgery at all. And how, I mean, going to an robotic surgery, how easy? Dr. Sudhir, your comments? Because we cardiac surgeons have no endoscopic experience.
Well, back in the days when we started, so me too, I had no experience. I mean, we all trained those days, splitting the sternum, stopping the heart or fibrillating the heart, and that's how I got trained. But later on, of course, in the late 90s, 95, 96 time frame, when the mid-cap era was just starting, so we really picked that up, and then, of course, we did a bunch of thoracotomies, and we call it thoracap, did like 800,000 cases before the robot came. And intuitive guys used to always ask me, why don't you get a system, but that time there were no approvals. So I said, what am I going to do with $1 million machine? We can do it all directly. But the idea was, stupid of me. In '98, without any endo-wrist instrument, I tried a TCAB with wearing these Vista goggles with a horrible resolution, like 400 something, and then, endoscopic instruments. Then we created a stabilizer using the ribbon retractor, cut out a U, and of course didn't work. But the goal was to really get beyond doing thoracotomy also, to get to the closed chest. So when we were building the hospital, that time I talked to Intuitive, the only reason I'll buy, I could be part of the trial. So we did go. Now, only thing differently that we did, of course, apart from the routine training. In my opinion, I think, yes, one must learn the system, but doing an animal or taking an IMA on a pig, it's useless, absolutely useless. And I know this is how somehow it has infiltrated, and because we all know surgery part of it. The only thing that we really need is how to use a machine. Yeah. And that's really where the focus. So we went through, and as part of the FDA trial, and this is where I think this becomes very important, as discussion was, how do you start a program? So back then, since we were going to be part of the Arrested Heart TCAP trial, so we had to do 15 IMAs, 35 pig heart anastomosis, dead pig heart. So really to retrain our fingers and wrists, and also develop visual cues, because there's no tactile feedback. And then to be able to work in a closed space. And then we did 2 IMAs, and then through sternotomy or thoracotomy, brought the robot, did the anastomosis with the robot. And prior to discharge, we did angiogram. So really we went through very systematically. Now I can tell you, unfortunately today, people will go and see surgeons who can do it. They've been doing it, they can look at easy, and nobody wants to go through very disciplined exercise. And especially when you want to get onto the TCAP platform, there is absolute need for pig heart anastomosis practice. And with different types of sutures, we used to take the right coronary from the pig heart, dissect it out, and use that as a craft. And my goal that time was to do the anastomosis within 5 minutes. We had U-clips, so we tried every single technique, U-clips, running suture. And we were able to do because it's all arrested heart. So basically, but then, and we made videos of every anastomosis, just to see how am I doing without tactile feedback, just based on the visual cues. And equally, then also this allowed us to train our staff, because the team training is so important. We are away from the patient, and sometimes people don't realize. Absolutely. And that can make your life very difficult. Table-side team, exchange of instruments, so the whole thing becomes then gradually efficient, and must practice. I mean, this is very crucial. When people talk of this, simulation models, I can tell you, we never had it, and we succeeded. The only simulation for us was practice. Absolutely. And I tell people, sit down on the system. Ultimately, you still have to operate on a patient. It's so easy to do on the computer, all kinds of things. But it doesn't give you. See, the idea is to develop muscle memory and reflexes, and develop automaticity, and that comes only with practice. How much to move with the scaling, all these different exercises that we used to do. Yeah. And it is very important to do. And then I think, yes, IMA, people who are doing thoracotomies particularly, then it became easy. For us, it was easy because we were doing a whole bunch of thoracotomy. Yes. So we knew how to look at, then the vessel identification. So we did really very step by step. So we'll take the IMA down because we were going to do thoracotomy. We were not doing sternotomy after IMAs. And so then next step would be do pericardiotomy. Started looking at the vessels. It started identifying the vessels, because now you've got limited view and all this thing. And sometimes diagonal looks like LED, and people have grafted diagonal. So I think it's important to start, and then if you want to get onto the TCAP, again, do step by step. One can, when the IMA is there, one can put suture up there. So just to kind of get hang of it, and then bring the stabilizer, put it on, because that itself is a little learning curve there. Because especially for the table side team, And they will sometimes, one time I was operating in Lenox Hill, Didier Lumet, we were doing a live case. And they put this thing right into the peritoneum. Oh. And the CO2 went, and next thing you lose the CO2 insufflation. And fortunately, I was able to repair and be conducted. So again, very important becomes, to learn these things step by step. And then, get on to gradually onto the TCAP, because TCAP it's a difficult operation, I will say, yes, but it is doable. So the question is, are we willing to spend the time? So I think, and then equally along the way, I think, people who are doing, if you have a case for ASD or mitral, which again, people who are doing MIS, so they know what to do, from the small incision. So it's the same process afterwards. And again, bigger structure. So it makes it easy to develop reflexes. Suturing practice is very important also, because how to load the needle in robotic world. So your hands are not going all over different angles and awkward. So I think, these are, so yes, is it doable from sternotomy to robot? Absolutely. I think most of it is, I can tell you, it's a mental block. Once you get past that, because it has been done, look at the video, all kinds of videos are today posted on YouTube and so on, and we have a channel that a lot of my old videos are posted there. So I think, do it step by step. Same thing with mitrals. Open the thing, put the suture. If it's taking longer, now good thing is core knot is available, so the times are shorter. But then if you have to, just close the atrium manually through, a small incision is there anyway. Just use endoscopic instrument. So, sometimes, one wants to do everything. And that's where I think sometimes challenges occur. Because not just you, but the team also is learning. Especially in the intracardiac cases, the team becomes so important. And yeah, because I have had these experiences, especially when you're doing telesurgery, you have no idea, and they can make life difficult. How to tie the knots. I mean, this is again, they all sound very simple, but if the knots are not tight, I had that yesterday, the cardioplegia site, knots are loose and spurting away. So we have to place 3 sutures to just do, because again, one is the instrumentation, and if you don't have a proper knot tire, it literally frays the suture. It rubs against it, and I saw that, it was happening right there. But what do you do? So I think make sure that you have the right tools, because these are doable, but they can be difficult if we don't have right tools and the right training. So people must learn how to tie knots with the knot pusher. It sounds all easy, but if you're not doing it, and for somebody who is going to do first time, it's not easy. And so I think if you look at all of these aspects as a total team training, it becomes very important to really have a successful program. And then commitment. It's just like institutional commitment that Ritvik said. And by the way, Ritvik, congratulations. I think, you've done remarkable progress, looking at that, learning curve and how the timings came down. Yeah. And doing 108 cases, yes, it may sound small, but if you look at even the US side, average number will be less than 50 in an average center, other than people who have, large referrals, etc., and proven track record. And it's perfectly fine. And then gradually these numbers will go up, because as patients become aware that they don't need to have sternotomy, they will come to you. You saw that. I used to get patients in India from wherever. So I think if you take this as a really programmatic approach and a commitment, collect your own data, look at them very objectively every single time. When we used to do, we will have every case, we will record it. And after that, my plan was to sit down in the conference room with the entire team. An entire team must be entire team, anesthesia and everybody. Review this video. What could be improved? So each time we learn from our own performance. So I think, if you do that thing, one can have a sustainable and successful program. Good thing is, when we were doing, we had nobody to teach us. Okay, now we are around, and there are many other people around, okay, to really guide and mentor. And now with tele proctoring, and telesurgery, we can actually help the surgeons. One comment I wanted to make on Ritvik, wonderful, I think you've done great and progress, very rapidly I see that learning curve. Regarding this injury to the ventricle, and again, you may be already doing, so one little trick that we had developed was, because in a single lung ventilation, and when they are still inflating the right lung, the mediastinum gets pushed, because you have created a pneumothorax, and it's not enough to prevent anesthesiologists, and sometimes they're a little more enthusiastic with the tidal volumes. So it actually comes. So what we used to do, first of all, I'll always put my finger, and we never use Veress needle, by the way. I know some people do, but we just figured out, put the finger, hopefully you're not feeling the heartbeat after you made the incision and you developed the space with the cautery. Put the finger there, and just prior to putting the cannula, the trocar and cannula, I will ask anesthesiologist to stop the ventilation completely, disconnect the tube. Yeah, and not keep the tube there, even if they stop the ventilation. If the lung is inflated in that, at that point, mediastinum will shift. And then just be gentle when we are putting, and also the trajectory. We never go this way forward. Always the first port that we put on the camera side, we basically go almost like close to 90 degrees. Go straight, because, and if everything is stopped, you have space, okay? And we never had injury. I had one time, those days Intuitive used to give this cutting trocar. And in fact, I had the director of cardiac surgery, from support from Intuitive, and we were going to do a thoracab actually. And so he came to watch me, I think we were going to do Bharat Mandapam. And and we felt it, but the lung, apparently it was stuck. And then with this cutting trocar, I did the ventriculotomy, yeah, on the left side. And as I pull the trocar back, I see the column of blood coming. I say, oh my God. So we basically, again, you don't panic. We put the trocar back to kind of, and then around the cannula, I extended the incisions and very gradually opened, took out and put my finger on the hole, and then we repaired and we were able to survive that patient and finish the surgery directly. So there are things that will happen. But I think now, with at least this is why a lot of people have asked to give sharper trocars. And we are very determined not to do that. Especially in abdomen, like in cardiac, it is dangerous. Yeah. And I think if we follow some of these tricks, these things actually, and occasionally things will happen. I mean, that's how life is in surgery. But no, don't panic. Figure out a way to deal with it at the time. And if you have to convert, you must convert. Sure. Don't wait for crisis to occur. Sure. That's the other thing, yeah.
Sure.
That's
Thanks.
it for me.
Yeah. Thanks, Sudhir, for your valuable comments. Are we ready or? I think we can do the next topic. Yeah. Not live presentation, we still don't have.
Yeah, Lalit called. He is, last night he did, yesterday he did TCAB, and Lalit always parties after, after TCAB or any other new procedure. And he called me last night with everybody having a glass in the car, and they partied late last night. So he called me this morning, sure. Yeah, running late, so sure. 9:45 I think they will be starting. Sure. Yeah. So we can go on to more presentation.
Okay. So here.
Yeah. We'll move on with the next presentation by Dr. Satish Kumar. Yeah. He'll be speaking on the first 100 robotic cardiac case at Manipal Hospital, Jaipur with the Mantra system. Over to Dr. Satish, please.
Good morning, everyone. I'm Dr. Satish from Manipal Hospital, Jaipur, and I am junior cardiac surgeon to Dr. Lalit Aditya Malik, and recently started training in Robotic. Because he was to present the live case, I am representing him today. And at the behest, let me congratulate the SSi Mantra team for hosting such a grand event. And now, my topic was our 100 cases experience, but I had to change it because we have already completed 130 and we'll be doing 131 today. So I changed it to our experience with Mantra robotic system. To execute a proper robotic program, the key requirements are a structured training, that is continuous learning and stimulation by practice. Good guidance is needed, that is mentorship. And we have had wonderful mentorship from Sudhir Srivastava sir himself. So he's a pioneer and his guidance is guiding us. Patient selection is the most important part because not every case can be taken up for robotic cardiac surgery, because we will be facing a lot of difficulties during the docking as well as and there are chances that we convert them, and that takes a very bad precedent. Technical expertise, we have been continuously training, and with a lot of help from the SSi Mantra team, we have been getting good coordination and the teamwork. At the end of the day, your training team as well as the surgeons need to be well experienced, and the anesthetist should be well versed with what we are going to do. That will help us do a successful program. And my mentor along with his mentors here, that is what we need. We all need someone who inspires us to do better and then what we are. This is the basically inspiration behind our telesurgery program and teleproctoring. Transmission of knowledge, that is what my consultant is doing to me, and he's also doing it to others. His journey in robotics was 16 plus years of sternotomy experience, followed by 8 years of MICS. He's completed about 1300 plus MICS surgeries and robotic surgeries. Now he's at 130. He's done robotic ASD closure, pericardial window, LA myxoma excision, robotic PAPVC repair, robotic MVR, robotic MV repair, robotic AVR and TCAB. That is the journey. This was the first case. Sir was present in the hospital, and this was the 100th case that we had done. This was the celebration we had done at after our 100 cases. Sir with my consultant after that 100th case completion. So this is the journey. This is our journey with SSi Mantra system. Total cases of 130. Today it will be 131. Started on 24/12 to 2024. First case was a TCAB. Sir was at the hospital. The latest LA myxoma excision is now converted to ASD closure, and that will continue. The case breakup, we had done 12 cases of TCAB, 15 cases of OSSD. MVR includes 1 case of mitral valve repair and 14 cases of MVR, 2 AVR, 5 LA myxoma, 4 PAPVC repair. Lima Rima down is about 12 and Lima down is 66. We had created 1 pericardial window using the SSi Mantra system. These are the patients that had undergone the procedure. This was the boy he was 18 years, and we had done an MICS ASD repair with PAPVC closure. That was sinus venosus ASD. And this is the second case. This is the video of the PAPVC repair we had done. I'll be trying to fast forward them. Initially, we opened the pericardium. This is the looping of both the SVC and IVC. That is the cardioplagia system opening the RA. Closure of the PAPVC using the Dacron patch. That is the closure of the sinus venosus ASD. Now we're closing the SVC. I mean, we are augmenting the SVC. Then closing the RA. So the next case is MICS MVR. First, this is the MICS MVR, and this is the robotic mitral valve replacement. That's the journey. And then the result of MVR here. Adequate exposure is one of the most important aspects of doing a robotic surgery. That is opening the LA. And for a good MVR, we need adequate LA size. That is when it will be helpful for you. AML is being cut. That is measuring. Now sutures around the annulus.
From Jaipur with Lalit Malik, he is assistant. Lalit Malik is getting ready with the case there. So the live case is got delayed. So we are on the talk, this is the second talk going on. They recently completed 100 cases, but yesterday they had 101. Yesterday the robotic recap was 101. So we were with Lalit. Yes.
This is cancelled. So do you want to?
Yeah, I can present this switcher thing for that.
That is the valve replaced. It was a bioprosthetic valve.
I will do this one.
Closing of the LA.
Talk about alternate switchers and cardiac surgery, robotic cardiac surgery.
It's the final result. So this is the case of mitral valve repair, that was MICS, and later on mitral valve repair case using the robotic system. This is the repair case we had done. Same. Opening of the LA. That is the ring placement. closure of the LA. End result. These were the two cases of MICS AVR and transaxillary AVR. So this was the case of robotic AVR we had done at our institute. Case of severe AR. Placing a vent, LV vent. Opening of the aorta. Ostial cardioplasia. Excision of the cusps. Sutures along the annulus. Placing of the valve. Closing of the iototomy sutures. Second layer of closure. Vent closure. And this is the end result. This is a case of pericardial window we had done. Slowly additions were released. Drain placement. This is MICS CABG, and this is totally endoscopic robotic cardiac surgery, robotic surgery. So taking down the lemur initially. The first few cases were around, we were taking around 45 to 50 minutes, which has now come down to about 25 to 30 minutes. And SSi Mantra system, the benefit is the assistant also has a 3D vision, and there is a octopus stabilizer system. That is, I have not seen a robotic Da Vinci system, but I heard it does not have one. We had done one TCAB yesterday, and we're planning to get that patient stented, the other two vessels after 48 hours, that is on the Monday. This technique of using the shunt in the lemur, internal mammary, was learned from Balki sir. The end result. I'll try to finish things fast. Then we do measure every case for TTFM after the graft, and this graft was successful. That is the patency with the PI level of 2.1. Anything about 2.6 is fine. That patient's TTFM. Because of the shortage of time, I'll try to rush things. Then now coming to the SSi Mantra system, it is totally a made in India module that we should be proud of. Modular multi-arm system, open face ergonomic command console with 3D and 4K monitor, 2D touch panel for controls, ergonomic hands controls, 40 specialized instruments that have been provided, affordable, telesurgery enabled, and compact design. Key technical features are 3D magnification with depth precision, 3D vision for the bedside assistant, wrist operated for tremor-free precision surgery, beating heart capability, and easy docking and undocking. Training and exposure, trained at SSi Innovations Delhi. They were totally helping us throughout a wet lab and dry lab experience prior to starting on the cases, proctoring supported by SSi Mantra. Initially time taken to adjust, now easier with time passed. Intra-op advantages, superior 3D vision and depth, enhanced dexterity for complex suturing, reduced surgeon fatigue, precise tissue manipulation and minimal trauma, good for beating heart procedures, smooth integration with table-side assistant because we can use it as small working port. What are the challenges? Not many limitations as of now found, and many of them have been previously spoken. Rare technical glitches. We have a support team of SSi Mantra during the procedure, so that really does not actually form a challenge. Conclusion, robotic surgery is not difficult for MICS or endoscopic surgeons. Continuous learning and simulation practice is necessary. Start with simple cases because case selection is the most important part. Proper planning and evaluation of patients prior to surgery. Never prioritize access over outcome. So we should always be prepared to open the case whenever necessary. Success is not final. Failure is not fatal. It is the courage to continue that counts. By Winston Churchill, the former Prime Minister of United Kingdom during the World War II time. Thank you.
Thank you, Satish. That was really an excellent presentation of various mix of cases. One question what I have is Dr. Sudhir Srivastava, for the aortic valve replacement through robotic. Do we have a robotic arm with a ronger? Because the amount of calcium what we are seeing, any chances of it getting embolized is always a fear for a surgeon. Sir, for the robotic arms, as we were seeing with scissors, what we were decalcifying the aortic valve, we were taking out prior to replacing. Do we have a robotic arm with a ronger wherein the amount of calcium which was getting dislodged was quite more seeing the video?
No, we don't have a ronger because ronger is really not possible in a, as a tip on the robotic side. Now, can we develop it? Yes. But I think the easiest solution is use monopolar scissors with the cautery on, and you will be able to literally, get at the annular area and then just kind of peel it off, and it works.
Because an excess calcified
Sam, you have obviously used. Maybe you can comment.
Sam can comment on that.
Yeah. So I think what Sudhir said, which is monopolar scissors with low electrocautery, so you don't do injuries. But then we use this device called the Rosano, which I think is available on the SSi, and it handles the calcium. But another important feature is the suction irrigation device, because that one is what's going to clear the debris. So those are all available.
I think you can always have a assistant holding a high power suction with a tip, and I think. That definitely will work also, right? Yeah.
Okay. So, any questions from the audience?
I had a question for great presentation. I thought those were really excellent cases, and execution was beautiful. For the case with the pericardial window, I think you did more than just a window.
Yes, sir.
Case. How did you decide to go right side or left side?
That was a door.
It was basically the CT scan.
There was a door.
There's a door.
It was basically the CT scan, sir, and calcium on the X-ray that prompted us to go on the right side.
Yeah, very nice case. Those are tough cases.
It was, sir.
You have done, I know, Sam, a lot of pericardiectomies with the robots.
Yeah, I think that's an operation that can easily be done with a stabilizer. And we have a series of maybe, 30, 35 patients, and the morbidity and mortality of pericardiectomy done on an arrested heart is much higher. And I think if you can do it off pump with no sternotomy, it's a huge benefit for those cases, because there's less myocardial edema when you release it from constriction. And so I think it's a great application that we don't see enough of.
Yeah, Satish, just one more question. You said you were doing CABG followed by stenting in the same sitting, shifting the patient to...
No, sir, I said 48 hours later.
Within 48 hours?
Yes, sir.
Okay, fine. Yeah, I think.
Thank you, Satish.
Thank you, sir.
With this, we'll move on to the next talk. I call upon Dr. Harish Badami to speak on the first 50 robotic cases at Mallareddy Hospital with the Mantra system. Over to Dr. Harish, please.
कैमरा ज़्यादा अंदर तो नहीं है ना सुजीत? हाँ ठीक है, अंदर अंदर कर ले, ठीक है.
Good morning, everyone. First, before I start this topic, I want to thank Dr. Sudhir sir for the support, and he's been the factor that we are able to start a robotic cardiac surgery program at Mallareddy, Hyderabad. So this is a presentation where I give a small journey about my experience and my analysis, how I came ahead from routine conventional surgeries to a robotic platform. So in India, the past decade especially has been a very remarkable shift from what is called a conventional sternotomy to a patient-centric specialty, where the same procedures have been performed with the least possible trauma. So as you know, conventional sternotomy has been the standard for decades. So, and you have various disadvantages or challenges like post-operative pain, recovery, the psychological impact of the scar, and limitations of early mobilization. So what the question that changed my thought process, can we deliver the same thing with less trauma? This was the point which made me to think about opting for minimally invasive procedures. So I started my journey minimally invasive in a, it's not even a tier 2 city, it's a small district of place called Srikakulam in the undivided Andhra Pradesh. So that was the place where I started my program. So initially I had even the challenge of acquiring the minimally invasive instruments. So I started doing the surgeries by using conventional instruments which were with long shafts. So I experienced various points like learning newer perspectives, like learning the anatomy in a different way, the same anatomy, and unlearning the new habits and use of newer techniques like cannulation techniques and use of echocardiography. So the challenges that I faced in minimally invasive was a steep learning curve. Definitely it was taking a very long time compared to the conventional sternotomy, and limited visualization and space for instruments. So at the end, the most important point was the balance between precision, the patient safety, and minimal access. So as I progressed to do those surgeries, now I have done more around 1,000 plus minimally invasive surgeries. So over the time I have started learning to do minimally invasive where it was relatively contraindication, like patients with obesity, patients with left ventricular dysfunction, unstable hemodynamics, and patient with lung adhesions. Then I ventured even into doing minimally invasive for patients with even redo cardiac surgeries. So as my experience expanded, we started doing complex procedures, double valve procedures. As you can see, slowly we started reducing the size of incision, which was initially 2.5 to 3 inches to almost 1 inch. Here you can see various operations which I have done through mix. The size of incision is only 1 inch. So what prompted me, like doing a 1 inch incision? So what's the need to go into a next step, go into robotics? So I could see that the biomechanics of the surgeon's wrist, elbow and shoulder does not get translated into through these small incisions through these long shafted instruments. So restricted access, visualization issues and ergonomic strains. So these were the points which encouraged me to go into the next step. So my first experience with robotic cardiac surgery, I think this, decision to start a robotic program. So starting a robotic program was not only a technical decision, but also an institutional leap. So you need the support of the institution and the system in which you are working. So at this point, I would personally like to thank Sudhir sir, Viswa sir, who had gone beyond the limit to support, because somewhere there was a imbalance between the system supporting me and the help I got from the system. It was at this point that they were very warm and they decided to support me to go ahead with the robotic program. So what was my first exposure to robotic was, it was very fascinating. At the same time it was intimidating, because there is no surgical, tactile feedback, and it's more depending upon the visual cues. And initially the complex system where you need to coordinate with a new system and you need to operate. So early cases. So the first 10 cases were very humbling, because we had lot of instrument collisions where I used to get fed up. How come these instruments are colliding? I'm unable to control, or my arm movements going out of the field where it's not recognized by the robotic system, and other challenges like prolonged CBB time. And I needed a constant, even after each case I used to sit down and think, what are the steps I've missed, or what was the reason I took longer times to do these things. And initially small steps like even applying for first 20-30 cases, it was difficult for me to apply clip also. Then on one case, Sudhir sir had done a robotic, a telesurgery to our center. I think the live cases which we created records, sir. So then I observed the way Sudhir sir was applying clips and their assistants, the way they were handling the robot at our center. So that was a changing step, especially in my lima harvesting program, where I'll show you a short video, the fineness of the movements, the amplitude of movements that sir used to use, and the changes which I was doing previously. So, and even applying the LA retractor, though initially 1 or 2 cases I could apply, the 4th and 5th case I had a challenge. So where I had to convert one case into minimally invasive. So that time also again I think I approached Sudhir sir, and he was kind enough to arrange whole of the teleproctoring. So that was the step where I learned to apply a LA retractor. So initial 1 or 2 cases I took almost around half an hour to 45 minutes to place the LA retractor. But after those things, after that proctoring by sir, it became very easy. So what are the key lessons that I learned? So you need to have a lot of patience, so endurance, and especially teamwork. This is the first place where half of the, at least a significant portion of the operation is shifted even to the bedside surgeon. So what did the robotic system taught me? See, you don't basically operate by your hands. It is basically your eyes and anticipation. So it's a transition from a tactile feedback to being a visual strategist. So the case selection is one of the very important factors which I felt during my initial part of the journey in robotics. I avoided harvesting even a lima in first around 15 to 20 cases in female patients, because I was not confident about the port placement. Patients with obesity, patients with left ventricular dysfunction, this especially patients with left ventricular dysfunction. It's a learning curve even from the anesthesia side, because I had seen 1 or 2 patients just crashing when we started insufflating the chest with carbon dioxide. And especially in patients with valvular pathology, like as the previous talk, the LA size is very important. Other factors like left ventricular function, pulmonary artery hypertension, RV dysfunction. Patients with aortic valve, especially we see the annulus, how is it, the size of the annulus, and the pathology. So as we shift from case 1 to 10, the docking became smoother, the docking time came down, console time also reduced, and slowly our confidence increased. So by the time we were doing the 20th case, the system was, we were no longer adapting the system. The system became an extension of us. So now at present we have completed almost 73 cases, and this is the various list of cases. So we have done around 47 lima harvesting, 7 bilateral mammaries, 10 ASD closures, 8 mitral valve replacements, and 1 aortic valve replacement. So just presenting a few videos where you can see how our program is present. You can see how to play this one. Yeah, you can see the initial cases where my understanding of the tissue planes was less as compared to the videos which I show you later. So initially most of the cases was pedicle. It was difficult for me to handle the branches of the lima. So it was more of pedicle, more of bleeding, and more of this one. So later you can see, then we switched on. Now we harvest lima by skeletonized technique, and we are able to use the clip applicator, application of clips, and less of bleeding. Initially, whenever I used to face a branch, maybe in first 15 to 20 cases, it used to become a nightmare. I used to get very uncomfortable, but now applying clips and harvesting the lima has become much easier. So this is a case of ASD closure. So the next stage was, as we gained confidence with the ASD closures and all, mitral valve replacement was our next step. So in all cases, I mean, because the visualization is excellent in robotics and we do total caudal preservation in all the cases. In India, mostly it is a valve replacement surgery that we commonly get. All these cases which I have done are mostly mixed lesions, mixed rheumatic mitral stenosis plus regurgitation. So debulking the leaflets. Bulkier PML calcified, so did a bit of debulking of the PML also. Reattach the divided AML. So as we advanced, initially 1 or 2 cases had to reconvert into minimally invasive because of additions. But as this one progressed, so we started doing cases even in which there were lung additions. Initially I used to put a finger and just do a bit of dissection, then where the ports can be inserted. I think I saw one of the paper by Bhalki sir when he had come to India to present in this one. That was the inspiration. I thought initially maybe I'll dock it on the other side and try out. Then one day I got an idea, at least initial basic dissection I'll do it out this one. Then I saw a sir's video in the Bangalore conference, sir. So, yeah. So the most important turning point was after doing these surgeries, doing an aortic valve replacement. So this was a case of young male who was working in a hospital. He had severe aortic regurgitation. For severe AR. Only concern was his ejection fraction had come down to 35%. So I was worried about the cardioplegia time and closure, aortic closure. So there was no mortality, conversion in 3 cases, and 1 case I had to re-explore. It was a mitral valve where one of the port site was bleeding. So this is the patient impact. At the end of the day, it is so satisfying for the surgeon to see the impact that robotic surgery has on the patient. So we have completed 73 cases. So what I can say is a learning curve not conquered, not totally conquered. It may be an initial learning curve, I would say, that we have crossed, and more importantly, a team that has matured and a program that has been established at our center. So future direction, we want to expand mainly into doing TCAP and complex cardiac cases. So somewhere a journey from uncertainty, crossing those challenges and reaching a stage of confidence where we can do more progress ahead. Thank you.
Thank you, Dr. Harish. Any questions from the audience? Yeah.
Dr. Harish, that was a great presentation.
Thank you, sir.
And congratulations on achieving such a high level of complexity in your cases after a very short time. 73 cases is very low for the things that you just showed us. And to be doing aortic valve replacements with the system, I think is very laudable. I thought your cross-clamp time was pretty short. That was a quick AVR.
Yes, sir. My console time was 3 hours.
Very good. Yeah, congratulations. I think this is a great example of what can be done with focus and commitment and paying attention to detail.
Thank you, sir.
Yeah, thank you. I think before moving to the next talk, Dr. Lalit is ready from Manipal Hospital, Jaipur. Lalit, can you hear us? Lalit?
I'm audible, sir?
Yeah, audible. Yeah, can you brief up about the case, Dr. Lalit, and also just put a word about the yesterday's the TCAP case? How is it? You can just tell it by yourself.
Yes, sir. Yesterday case was extubated in morning, and patient doing well. Very minimal, only one epi on 4, and basically patient was on diplet before the surgery, before one night before. That's why we keep patient overnight intubated. I saw Dr. Balki extubated on the table, and I think, but we are extubated after 4 or 6 hours later on. And but this patient we ventilate overnight because of maybe some issue of bleeding that is in our back of mind. But patient doing well and extubated, that's a good thing. And now today we are planning for ASD closure, and we have a good team. In anesthesia side, we have Dr. Satish and Ram. On table side, we have Sujit, Suresh and Bhavar. And for professional side, the Tulsi and Stebi, and Ansari is our OT technician. So we are now, I hand over about case and T and some patient brief, and in every case we put a blocker, some death relief pain intra post-op. So hand over to Dr. Satish.
Hello.
Yeah, please go ahead.
So basically, she's 31-year female. She was diagnosed 2 years back. She had a complaints of palpitations. 52 kg, 31 years female. Large ostem secundum ASD, left to right shunt, moderate TR. So she came to us with no comorbidities, no past surgical histories. Again, careful graded induction, 2 arterial lines before induction, 2 wide bore cannulas, intubated with 7.5 French tube. And easy bronchial blocker was put, which was 7 French size, to isolate the right lung. For every case, thoracotomy as a pain management part, we give deep serratus anterior plane block in the 4th intercostal space. Yeah. So
brief about something. This yes. Where?
So this, you can see also on the screen. So the drug is getting deposited below the serratus anterior muscle in the mid-axillary line. So it spreads craniocaudally and blocks the intercostal nerves. So it is very helpful in post-op. I add dexamethasone in this. It usually lasts 16 to 18 hours. If needed, again we give single shot block before shifting the patient. So next we put.
1 minute. Yeah, this one.
So for her, she is having persistent left superior vena cava. There is no innominate vein. So we put her 14 French cannula through right IJV. It was confirmed on the TE. I'll show you the images. Yeah.
T.
Yeah, here you can see the guide wire coming to the SVC. Patient was heparinized before, after the guide wire was confirmed. Yeah, so this confirmation done with the saline flash.
Patient have a left SVC.
Yeah.
That's why we put today 14 French, otherwise we go normally 16 or 18 for SVC.
So these are some of the images, TE images, 4 chamber. Yeah, see this large ostium secundum ASD, left to right shunt.
Your patient has an LSVC?
Yeah, patient has LSVC.
Yeah, that's why, that's, yeah.
You
Go on, sir.
cannulated the LSVC also? No.
No.
Okay.
So we'll put sucker additional.
Yeah, we basically we put the because size is small, so we put a small size on right side as usual. But this time we put 14, otherwise we put 16 or 18. And plan is put sucker directly inside, not we are not going to cannulate outside.
Yeah, please go.
Yeah. Yeah. This is bicaval view, good SVC, IVC margin. Posterior inferior margin is deficient. Again, the bicaval view. Yeah, here you can see the LSVC, sir. See? LA, mitral, LV, LSVC, and left pulmonary vein coming. TR, mild TR. Inflow, outflow view. Dilated RA and RV. Short axis aortic. So then after this peripheral cannulation, right femoral vein and right femoral artery was done. This we also confirm on the TE. So this is the guide wire coming in the descending thoracic aorta in long axis. Guide wire coming through IVC in RA. Yeah, this is the tip at the IVC RA junction. So then after achieving ACT, we'll go on pump, antigrade, the cardioplegia will be del nido, 20 ml per kg. We'll put additional vent or sucker in coronary sinus, and we'll come off with milrinone. After achieving hemostasis, if hemodynamic is stable, in ICU, plan will be to extubate early.
Yeah. So this is our port placement. This for camera. If you see, camera is fourth intercostal space, just 2 or 3 centimeter enter to enter exit line, and this right port is 4 finger away in 6th intercostal space, same line, and for left side little anterior for this left one. And this is old picture we put. Now we use today we use this soft tissue, small soft tissue detector for and last few cases we did this 4-port. This is 4-port is same fourth intercostal space, 3 centimeter below to this camera port, same in fourth intercostal space, and this is 12 mm port. And by this port we are pass suction, and we pass the patch, and we close ASD or PVVC by this 4-port system. But today we are, I show you today what we going to do.
Yeah, Lalita, the LSVC is bigger than the RSVC in the echo?
Same, sir. Same.
Same size?
Yeah.
A question to Dr. Balki, sir. If you have an LSVC, and would we cannulate the LSVC rather than the RSVC if it is bigger size? If you have an LSVC, so we would cannulate the LSVC if the size is bigger, or still what is your recommendation?
I think the cannulating the right SVC is adequate usually if you can get a big
Irrespective of the
enough
size of the
cannula.
LSSC.
Disrespective, yeah. I don't know. What would you do? Would you cannulate from within?
Yeah, if that is bigger, then from the left side only, not from within. We would cannulate from the neck, left side of the neck as the minimal access, we do cannulate, so we can go to the LSPC.
Yeah, I think that's a good strategy, and then you don't do this one at all.
No, not on the right side. If it is right, is smaller.
Yeah.
Dr. Sudhir Srivastava, sir, your comments on this?
I didn't get your question.
If we have a left SVC and a right SVC both in the case of an ostium secondary ASD or any case which we are doing by minimal access or robotic, so the one which is larger we cannulate. So wanted your thoughts if the left SVC is large and right SVC is smaller.
Yeah, I think obviously you will go through the larger.
The larger from the neck itself.
Yeah.
Makes more sense.
Yes.
Hello.
Yeah, Lalit, please go ahead.
Yeah. So today the same 246 why I told you, and but for this case we not going to put this fourth port, 12 mm port, the same for the this is one finger. This is our working port, and we use sucker already put this one. Before going on the pump, and this is the chit put, the same line, sometime 3 or sometime maybe 4, depending upon the aortic position. And for cannulation, open technique, we use same like in MICS. We are not much more confident in percutaneous, so we open up and take pusting and going for cannulation. So now we put femoral, both I think 24 for femoral vein and 16 French for femoral artery and 14 for SVC. So this is our cannulation part. So now we are ready to go on pump. So any other questions, sir?
I think Lalit just point out, and I know you showed that picture of that fourth port. And ASD particularly, in fact, once you have a good table side team, you don't need to create this soft tissue working port. You can put regular cannula and use that as a working port, because if you think about it, what all will occur, basically you got, cardioplegia, so you give a single shot, take it out. You don't need to leave it actually. I mean, we don't do that anymore. We saw that yesterday. Secondly, we can bring an umbilical tape, and what we did, you just kind of put it there, clip it and cut it, so nothing is coming out to your working port. So the only thing that will go now will be the needles, and the size of the needles. 4O generally are used for almost everything, other than the 2O sutures. Again, they go through the port. So literally, you can avoid a working port, but you do need a good table side assistant.
Yeah, sir, you are absolutely right, sir. And that's why we are from last case, we use this 4-port system. But actually, sir, what thing I found in some time, this 12 mm, when we remove this after completion of the case, the size of this 12 mm is sometime is a little more for this small one finger, one port. And sometime in one case, I found later on bleeding. And maybe the today is maybe in live case, and this is one of our hospital doctor relative. So we are more. That's why we are using this type.
No, I think it's perfectly fine for a live case.
Yeah.
I think the port blast, as far as the port bleeding, again, I think we all know in intracardiac cases versus
yes. No. So this is
because of the heparinization. Mostly ports will be the one oozing afterwards. So very important to have a look at it and really just deal with it right before you leave.
And
yes.
Sudhir, just one question. How do you do de-airing once you have removed the aortic?
We basically that whole, firstly you start out with CO2. Okay. So we flood right with the CO2 as soon as the camera port is put in. And then run around, once you have the working port, like if you've got 4 ports, then you can run the CO2 still on, and then you reduce it to 3 liters or so per minute. and that hole is there. And when you take out, so yesterday I did also, release the clamp, just, you can do that after putting the suture, release it, let the air out, and then be ready to tie. It really is not a problem. Yes. And as long as
left,
somebody is not sticking the sucker in the, through the defect. Right?
Yeah. Sujit, left, ज़्यादा instrument देखना.
Lalit was partying last night, that's why we are delayed.
No, sir. That's what basically last day case was actually we choose one day before and it's completed well, and so a little celebration for with our team. Just sir.
There is never a little celebration for you. All right, let's continue.
So can I go for pump, sir?
Yes. Yeah, I think you can go on pump, and sir, we have the next talk as he comes up to the main part. What you would recommend?
Yeah, I think,
go on.
Why don't we see initial steps?
Yeah.
And then we can, I think we have time today.
Yeah. So, Lalit, I think as you do the procedure, I want you to just keep talking for the benefit of the audience here.
Okay, so I'm ready to go on pump, and I always start from open SVC. It's always better to check, and this is the same practice I used in MICS case, because IVC in your control, and sometime anesthetic put, and sometime there is blood is not coming from my SVC sometime in your initial case. So I make a rule, I open first SVC, check patient happy with SVC flow, then I go for open IVC. So please open SVC, please. Yeah.
Can somebody show the even the pump aspect also, how the pump is set up, where exactly the pump is placed?
Okay.
Can the camera be focused there also?
Yeah.
In between, whenever.
Yeah. So that part. उधर ले जाओ इनको कैमरा. Sujit, Tulsi, happy? Open IVC? Okay, please open IVC. Operion 30. Okay. So now we are on pump and Operion 30. So we start, these are cutting and coagulation both.
I think this, you're seeing the assistant with a grasper. Yeah. And I think that is a wonderful thing to have, because every little help from the assistant in counter traction or exposure is always very helpful, instead of, you trying to do everything.
40.
Wish I had yesterday. And I think this is where it becomes very important that if you have a consistent team, the whole procedure becomes much, much easier and efficient.
Sir, at this point, I would like to put a suggestion, sir, because for SS Mantra, wherein the physician assistants who are there helping at most of the centers, after the completion of course, they need to do an additional certificate course for specialty in robotic. I think that will make a difference for most of the surgeons' life, because the surgeon sits at the robo console, the person who sits at the side, if he is not good enough or does not follow the steps, then it will be a disaster for us.
Yeah.
So somewhere
I think, when we do start out our 5-day courses, the plan is to include the whole team to train all the way, and including all the various surgical steps. Yes. Because see where the time gets wasted when team is not anticipating. And each time, it's amazing repetitive motions. If you are not ready, then it just adds to time. And especially in the intercardiac cases with the clamp on, one really needs to become more efficient. And equally, I think the table side, if you have a PA, they must learn all these little tricks. The suture management, and they must practice outside. Sutures don't get entangled, how do you avoid locking, tying knots, all those steps that they do are very, very crucial.
Yes, sir.
And
ठीक है सुजीत.
I know Sam used to has a wonderful team, and that really makes life very easy. And same thing when we were in US, great team, and that really makes it very easy to keep moving. Yes.
I think in the long run, we need to have a robo sitting beside the patient to help the surgeon feeding the sutures and all. Yesterday, the way you demonstrated one.
You want the robot to do it? No.
No.
Look, we are working also on humanoids, and look, this is like a question always: can we do it? Yes. Should we do it? Mostly the answer is no for such adventurous things. So, someday, yes, but I think it will take us time, and it probably will occur faster than we think. But, see the human, when you really think about autonomous things, especially when you talk of surgery, you have to feed like 10,000 videos for AI and machine learning for it to figure out automatically. And yes, it is possible, but all kinds of algorithms that are necessary.
Yeah.
I mean, this will be an engineering feat, and it will be doable. But I think especially in surgery, with all the variations that we do, all kinds of things, things that can actually occur, where human with an experience and teaching and the base knowledge has to figure out very quickly and deal with it. Now, by watching, so unless you also teach the robot, these are the complications. Hopefully not too many videos will be there like that. So, just think about it, something that goes wrong, how is it going to determine what to do? Isn't it? Because they're going to depend on the entire computer vision and what you have fed. So, yeah, I think we need to look at all that very intelligently. IMA takedown, for instance, you operate on the image day before, and you program it, and must be available, and yes, it is doable, it's a stationary structure. So there are things that I think we can do, but yeah, to have completely, you need a humanoid with human intelligence and not augmented intelligence.
Any questions from the audience at these steps where Dr. Lalit is taking? He's fixing up the pericardium.
Yeah, I always use this stay suture, hooking suture, and I made this modification, this node automatically the single one, and this pull, and like this. So no need of pulling two suture.
What was it called? The Layla and loop. I had big Layla loops there.
Clean. Thoda sa. Sorry. Yeah.
Thanks for telling. I think it was, yeah.
Clean the camera, please. And one more thing very important, when you open pericardium and this distally, so always look for phrenic nerve. Sometimes phrenic nerve curve is a little different, so is very important step for open pericardium till the end.
Why did they give you the big mega needle driver, Lalit? Or you like the mega needle driver?
Yeah, Sujit.
The LSVC, I think, did he do a CT angio? Because if you have a LSVC, then you'll have to look at the bridge anyway. If If you have a big bridging vein, then taking just trading the right SVC is fine. If you don't have a bridging vein, then what the SVC does is it warms the heart also.
Right.
Whatever sucker you put, it will still warm the heart.
I think.
Yeah, now I can speak.
So, Lalit, do you do a CT angio for all your patients?
No, sir. Sweet for fish. No, sir. No for CT angio. I do just Doppler. If a patient is old or something like that, then we plan CT angio.
So in our institution, it's a routine practice to do a CT angio for all the patients who are going into robotic, because what we feel is the field of vision change, the field of surgery changes. The field of surgery starts from the neck and goes up to the thigh. When you're doing a robotic, normal cardiac surgery, your field of vision is in the chest. So whatever problem you have, you can handle it. Sometimes you have an unexpected IVC interruption. How do you handle that? So you tend to have a lot of anomalies and a lot of things which are missed. You may have a PDA sitting there. You never know. If you have a PDA, you'll be in trouble.
Can you pull this
a very protocolized system where you should, in any mix or any robotic surgery, you should not be having surprises on table. Dr. Balki?
Okay, give me Operion, right?
Yeah, I agree. I think CT angio is pretty much standard now for... I think if you have a young patient where you don't, most people are looking for aortoiliac disease and plaque, not necessarily congenital anomalies, but I think the concept of doing a CTA on everybody, what they call a TAVR CT.
Okay, give me, come on, 20. Standard.
So we have an experience around doing 50 ASDs, and we have picked up all sorts of anomalies in those 50 VSDs. We are thinking of putting it down and writing a paper on it. So we have seen IVC interruptions, we have seen small PDAs.
Suction, please.
If you have a small PDA and you are doing a robotic ASD, it makes your life hell. It is not easy. So
you plan devising of that PDA and then plan for the ASD?
So all these patients we always plan, we look at them, because see, congenital defects, we all know as cardiac surgeons, bring a lot of surprises. You may have all permutation combinations for with a congenital heart defect. You may have be sitting. We have a patient recently admitted. Somebody did a minimal invasive ASD. Patient was kept on having severe PH. Now patient has come back to us. The cotra atrium was missed, and the pH has not come down. So we have to now operate the patient to the cotra atrium.
So what is the smallest size of patient that you have done robotically?
Our smallest patient was 13 years old.
Open? Yeah.
So for us, the cutoff for the femoral is around 5 mm. With 5 mm, we are able to manage.
So it weight?
5 mm means you have 14 cannula femoral. We don't have a 12 femoral cannula.
But you don't do direct cannulation of aorta by...
No, not robotic.
Never done it.
Okay. No, not robotic.
How would you deal with the PDA if you saw PDA?
So we'll do a device closure first for the small PDA, and then we'll
prior
do and then we will do a robotic ASD. It's
up to the patient,
actually.
Give me marker.
Have you encountered one intraoperatively that you were not aware of?
No, sir. We started the program. We had a very protocolized system. Every patient undergoing a robotic cardiac surgery has a detailed examination by a CT angio. The problems we encountered were the IJV was very small. So we took the patient in. The IJV was very small.
Okay, change.
So we have now increased the field of our CT angio, which you call a CT. So you have to tell your radiologist. So what we've done is just increase the field and look at the IJV size also. So for us, all patients, we look at the IJV size, we look at the CFA size, the common femoral vein size, because problems of the neck are the most problematic. Femoral you can expose and manage. Neck is not a simple problem. If you have a problem where you put in a cannula and it goes and you have a problem in the neck. So one patient we had to actually do a small cut down in the neck. So the neck incision is equal to the robotic incision.
And how about using ultrasound for neck? And because I agree with him, Dr. Balki, because doing femoral doesn't involve so much of a dye, but if you do the whole body, most of our patients are badly diabetic with nephropathy and all sorts of things. So
you can do an MR angio in those patients. But the important point is that the field of surgery, whenever you are doing robotic cardiac surgery, is not just the thorax. You are exposing a patient from neck to the groin and the distal cannulation. Whenever you are doing a perfusion, the distal limb is also, if you talk to Dr. Balki and a lot of other groups, Dr. Neerav Patel, and they've done a lot of work on distal limb ischemia. Yeah. And it's a topic which everybody needs to understand. Femoral cannulations can bring in problems. What do you do with the distal perfusion? It's a question I think literature is still not answered. A lot of groups don't do a distal perfusion, they use NIRS. A lot of groups do a distal perfusion, irrespective of Dr. Bhadwar's group does a femoral distal perfusion, irrespective of what is the CT angio. Some people don't do it.
Yeah, so what, why I was asking you is we have modified this by we do Doppler 2D echo for heart and upper extremity and definitely CT angio for lower, because if you have a femoral complication, it's a disaster. So that's what is the modification. Yeah, thank you.
And I must say that this 3D vision that we have given to the tableside team is really helpful, to make the steps efficient and avoid accident. And we are working towards these glasses also. So I would actually encourage, and hopefully we'll have our team set up in the Tele area, these glasses, and beautiful resolution. We are hoping to actually
give me Cotry, sir.
To the table side,
1 minute.
especially the
yeah,
system,
out.
who can just wear
Cotry,
it, so you
yeah.
don't have to
Fill the art, please.
all that to kind of see between the arms.
Little bit. Give me Cotry.
So the system we use these days are 3 ports and 3 instruments. So we use a needle driver only to loop the SVC, and the IVC we use the Riles tube. So that's also something which we have invented. So
what is the last one?
So we use the Riles tube. So we take a small green Riles tube. We stitch a umbilical tape double-ended to one of its end. And we use the needle driver to make this. So we are not using all those instruments. So we take only 3 instruments when we are doing a ASD. Yeah. One is a Debicki needle driver, and the third is a MCS. That's all the 3 instruments we use. So our ASDs, we use only 3 instruments and 3 ports. So we don't use a long pickup. We don't. So our technique is quite simple, and we are going to present it in the EACTS.
Lalit, are you going to loop the IVC? Is that what you're doing now?
Yeah, sir.
Why?
No, okay. Oh, no, okay, give me that one, another one. So, can I open this, leave it? I always, this,
see, if you keep the cannula below the junction,
mostly I think
you don't have to, mostly.
Yeah, definitely, sir. But I thought today that patient have left SVC, so more blood is coming, that's why. Otherwise,
you need to just open the oblique sinus. You don't, just hold it a little bit below with the other arm. And you have to just open, I can see the oblique sinus there. Just open that sinus.
Yeah, it's very it's translucent. And you can just poke through it. Yeah, you don't have to do all that dissection actually.
No, this is, Can you...
Lalit, take your time. They all have the courage of the non-combatant. You should take your time and do it the way you want to do it.
It's easy to talk sitting on the bench.
Okay, give me this another this soft tissue. This one. What we use?
And I think, and I'm sure these right angles, some drainage things are available. And I tell you, it is worth investing into that.
Suresh.
Much better and
Dona.
easier to manipulate instead of this thing you put in and then it has its own memory and flops.
Give me instrument.
Yeah, I think the concept of using a limited number of instruments comes from the financial, aspect of using more.
Suresh.
But one model
Instrument
could
dona
be
aage.
that the payment is per
Right.
case. Because when you do a case in an open setting, you have access to 100 instruments, and you use the exact instruments that you need. Why do we compromise our choice of instruments when we're on the robot?
वो दो ना
So there has
soft
to
tissue
be some kind
वो
of
क्या बोलते हैं
evolution
या अरे
of
इसमें कर
the
यार दो ना
payment
जल्दी
as opposed to per instrument, it is per procedure.
Instruments in our institution is free, so we can open 10 instruments in a case. Nobody will ask a question. But we require only 3, so we open only 3.
But if you needed something special for that case, you have
So
no
yeah, we have no problem. So the patient interest is never compromised.
Yeah.
But the system which we have been able to develop, you don't need the 4th instrument. See, he's doing the same technique which I was telling you. Yeah.
Listen to you.
No.
It's actually, I think it's obviously in India particularly, the economics play a great role.
Yeah.
In US, of course, you have got packaged pretty heavy reimbursements, and it doesn't matter. I think because these charges are passed on to the patient, if insurance is not going to cover, and every 10,000 rupees is 10,000 rupees. And if you can really also, you can figure out a lot of things. I'll give you an example of Venki, colorectal surgeon. He uses 3 arms, even with Da Vinci, and only 2 instruments. He does the entire case with that. He's got an assistant who is very good, and so he never uses 4th arm. Does 1,000 colorectal cases. So it is really, obviously some of it is necessity.
Change my right instrument.
And some of it is creativeness of the surgeons. Yeah.
Advanced clamp. You saw this, sir, IVC technique is okay?
I don't know.
Is it coming out of the working port?
Well, listen, you can just, if you are going to just put a clip, and you don't need another tube in there.
Yeah,
Find the
I
working
know.
space. Since you asked, actually.
Yeah.
Yeah, advanced, yeah, okay.
I think one thing we must
Give
also,
me,
as much as possible, keep very little, don't have a lot of things coming out of the working port. Because when you are passing sutures, when you are pulling sutures, there's a tendency to get in. We saw that yesterday.
Yeah,
So
Sujit?
despite even the pericardial sutures, and I have a feeling that they did not
Open
have
up.
this proper hook, so they must have brought it through the working port. And
Yeah,
when you are putting
well-
this thing, your thing can go behind it, and now you have got to figure out again, and you waste time actually.
Sir, for the IVC and SPC looping, sometimes we use those larger vascular bulldogs. Can the robotic arms help us inside to?
Yeah, we have done actually. We have done bulldogs in,
Cardioplegia flush karao.
if you have the right bulldog.
Yeah.
And I have used in ASD's bulldog instead of even looping.
Tulsi,
Yeah.
Sujit,
Places
Sujit?
that had bulldog, you just drop it in, you use your needle driver or one of the long.
The
Sujit?
needle driver we can use.
Open it
थोड़ा
and
push
then-
करना नीचे
And
से.
it comes also with an applicator these days, yeah. So you
थोड़ा
just have
push,
to apply
more
and
push.
leave it there.
Yeah.
And especially if it is a little bit angled, completely stays out of the field. Yeah.
Is okay na? Okay. Leave it here. Sir, today we are going to this direct cardioplegia things. Okay. Okay, it's okay. Flush the cardioplegia, please. Okay. Advance, 1 minute. 1 minute.
So this is a custom-made needle in India.
Yeah.
I think somebody, Satyaki worked on it? Yeah, right.
Advance, yeah.
And the only thing is when you have to do repeat, then hopefully you will get in the right hole. And that's why the thing is there, but.
Okay.
I I think one of the things that we do is just bring this, cut out the flanges.
Okay,
Or if you
okay,
have a 14 or 16 gauge needle,
okay,
just
flush
come
down.
lateral to the
Yeah,
IMA
Tulsi,
and just go
Sujit,
straight
clamp.
and leave
Yeah.
it there, and it doesn't pop out. And then it's there
Give
for
cardioplegia.
healing later on, or repeat cardioplegia dose.
So what we do is we put a pleated CV Cortex suture, and the way we do the open technique, we put the cardioplegia needle, and then we also put a reinforcing suture. So it helps you. Sometimes you're doing a mitral valve, your time is going up. Your LV is not so good, especially for mitral repairs. If your LV is not very good, you need to work on your myocardial protection. So we keep all the options open.
Yeah.
Yeah,
And,
you are right,
can
sir.
be because robot
we
allows
use-
you to take purse strings. It
Right.
allows
Yeah,
you
yeah,
to
yeah.
whatever you want to do inside.
Yeah.
That is not a problem. So
Yeah,
Yeah,
only thing
we-
is through the working port, there's tourniquet coming out. So we
LV,
just bring it from here.
empty.
And you can leave it there, or you can even have
Snug
a
SVC.
suture and just, secure it right there instead of another tube tourniquet. It will stay in place, Yeah.
we use Dr. Lee's technique. Sir uses a very beautiful technique. So he puts a blocker, and the thing goes inside in the pericardium, in the pleural cavity. And once you're done with it, you just pull it back. So the snugger comes out. The snugger is blocked by a blocker, and then he puts it in the pleural cavity. And once it is not required, he pulls it back and then uses it. So nothing comes out actually.
I see.
Who does this?
Dr. Lee,
Oh, Dr. Juwan. Okay.
so can you just tell us about that technique? The cardioplegia technique which you use.
Cardioplegia is very important. Sometimes we have to take ischemic time for 3 hours. In that case, the single cardioplegia should be sufficient. So we give a lot of crystalloid, and then I think it is good for up to 3 hours, is my experience. But some surgeons now using Tele, that is not that take long. That only 60 minutes or 70 minutes. So I don't like Tele. I just put all the crystalloids. But I give 5 minutes.
How much time left, Tulsi?
That take about 3 or 4 liters sometimes.
जल्दी देना क्या मजे से दे रहा है?
Why was this catheter or this cannula designed to be bigger down where the delivery is? Why isn't it the same diameter? Do you know? Does anybody know?
Sir, this cannula have a different this part. We have the same thing, and we can adjust same the needle size are we have a different needle size for this. We can attach different needle with this cannula, and we use this direct cannula only ASD cases. And what Dr. said that for MVR we using this pleated suture because sometimes we have to repeat cardioplegia. So in that MVR or MV mitral valve repair, any other TV repair with any other case, we go for this suture with suture cardioplegia. Or sometimes we use the cardioplegia from the second intercostal space that I learned from Dr. Sudhir Srivastava. Sudhir Srivastava sir use this from second intercostal space, direct put this long cannula inside. But this cannula come from the working one, and we use this one and we mark this one because later on maybe in case we use again cardioplegia, or maybe after that closing of the aorta after deering. Yeah.
felt that this is the Achilles heel of robotic ASD closure, the cardioplegia site. So that's like sometimes it bleeds. It is not a very good story because when it bleeds, the blood comes in a camera. So this is actually the only Achilles heel of this. So people have different ways of doing it. So a lot of groups just put a needle. Sir did yesterday. Take the same cardioplegia and put it inside and take it out later. So, but what we have started doing is what we do in an open surgery. You take a purse string and it's pledgets on both sides, and we use a core knot after that. So that is an off-label use of core knot. But you have to keep it a little bit higher, otherwise the core knot can bury into the RA later. Because it is not, it's going to lie there, and once your RA is big, it may cause a hole in the RA. So if you're using a core knot for cardioplegia, you have to take it, your planning of cardioplegia has to be a little bit higher on the aorta.
1 minute.
Maybe when we do get to, so I'm going to share some information on what we are working on, developing new sutures. And whenever we do get a break here, then I'll do my morning presentation in the afternoon, because I haven't prepared it yet. Global. Sam just gave me his slides.
Sir, I think it will be worthwhile to develop a small C clamp, robotic clamp. Yeah. It will make life for, you will be able to handle all the problems which sometimes you encounter. So if you have a robotic C clamp for cardiothoracic surgeons, a small C clamp, that would make our life lot easier.
Yeah.
If you can have it robotically. Put. So if you see, problem, sir, is that if you've taken a suture, that suture has given way. You have a 60-year-old patient, you're doing a mitral, the aorta is bad, the suture has given way. So what is your backup then? You will take out the suture once you've already DA'd. You're near to come off, you're coming off pump. Yeah. You've already warmed up the patient. It's the last step of the surgery. And if you have a problem there, then how do you handle it?
I think one of the things, we did yesterday also, when you have that type of thing, instead of having a snare, you can just put one of these hemolocks, and it will hold it in place, and it will come off when you have to do. Also, that can be used initially. To push, actually. I mean, see, when you're tying these things, directly, guys saw
vent dena to Sujit. Vent.
It was loose, and it's a nuisance. So you can slide
put inside
down while pulling this thing, and then you can tie and just.
Sir, core knot is a good idea.
Tricks can help.
What we found, core knot is a very good idea. Whoever is your bedside assistant, if you are using a core knot, it's a very reliable way of closing.
Yeah, right. Yeah, well, I do not know. Yesterday they had the core knot in Puttaparthi.
Give me silk, no. Silk, give me Prolene.
Will you start your talk, sir, or wait for the procedure to get completed?
I can just show it's a very brief actually.
Prolene, this one.
5-7 minutes.
Yeah. Lalit, we'll just go with the next talk here. As we are closing the ASD, we'll again join back with you.
Okay.
Yeah. The next talk is by Dr. Sudhir Srivastava. The topic is alternate sutures in cardiac surgery.
Can we have it on the screen? I think you can leave the surgery going on, a couple of them, and that way we can keep watching. But can you get it on the screen? Are you looking for this? Okay, just a second. Duplicate. It automatically comes actually. Okay. Yeah, just, no, it was fine, I'll deal with that. Go back. Yeah, no, it's right here. Yeah. Just a second, guys, let me manage. I know what to do. It needs to go into the slideshow.
डिस्प्ले भी तो मैंने कर दिया मैंने तो वही
All right. I'll just keep it very brief, just to give you some ideas about what I know. There were a lot of discussion yesterday about sutures and anastomotic techniques, etc. So this is what we are working on right now, what we are calling it knotless, SSi knotless. And it is a very small clip. It's really, it looks big of course here, but it is very tiny. And so one end of the suture is stretched on, and then you have basically one needle, and once you put, then it literally it will open up here, and then you press it and you're done, and it will hold. And we have tested actually on the prototype in the lab. So this is how it will look. Again, looks big here, but it's very, very tiny. We were talking about, you know, this whole core knot type of thing. Core knot at a smaller level, it is very difficult to make actually, and of course the company has figured out who are doing it, but to get it to this thing, and also because you need to still have two sutures on that core knot, and they go out and somebody else has to do it. This way, these are going to be short length, like the old U-clip, 15 to 18 millimeters maximum. And this way we can use the technique that we had developed way back in 2002, whereby we'll put 5 of these while the IMA is still on the chest wall attached. So you can do that ahead of time. And the main thing at that point used to be that we will leave the IMA attached in multiple places. One, for the reason that if you free it up, it will lie on the pericardium. Secondly, also you leave it attached and then do not divide it also. So used to leave that toe part intact. So a lot of these little tricks gave nice counter traction. And so we started out with the heel, and then on the opposite side of the surgeon, from outside in, we would place these things. So they will be hanging there. And also we used to use another one to place about several centimeters away from the spatulated end, to be able to drive that through the epicardium and secure it in place so that it's not flopping around. And so this is how we're working on this right now. And also same thing for the valves. So 2O suture, and again, you know, Sam and I, we were discussing, you know, different ways of doing it. So suddenly now you don't have suture management. It's all inside. So, you know, because you bring sutures out, you organize in that organizer, and now you're dependent also on the assistant to kind of hopefully feed the right one in when you're bringing it down. And we have seen that, you know, sometimes you get the wrong suture and you have to put some additional suture. So this will really allow much faster way also of doing. So this is for the valve we are working on right now. Now this is the concept actually, and I know this company Octocron in Netherlands, we have modified it. We have looked at the patent side, and I don't think we will have issue with that. And again, what we are looking at is a compliance side of things, because anything that is rigid, only thing is because it is on one side of the valve or the wall of the vessels, whether it is IMA or the coronary, you are still retaining compliance actually. And the way we are doing it, making it very thin and putting actually a little silicone thing on the top side, and it will literally make it watertight. And so this is actually a wonderful concept. In fact, way back, Medtronic had worked on this thing. And then, of course, a lot of these things were dropped off. And so essentially the way it works is that these hooks, the way we are designing that, they will not penetrate the wall. And they will basically hold it from inside. And there is a mechanism that we'll talk about. And then essentially these two components, they literally snap. You just press them and you will be able to do it with a black diamond, and then it will hold it in place. It will be relatively fast in terms of achieving this thing. Of course, we are working on Nadi, and I'm not going to show that. I think everybody is aware of it. We have shown that other times. Of course, that will be wonderful. I must admit that manufacturing of that at a literally 5 to 10 micron level precision is not easy. And especially there are quite a few parts actually, but hopefully we will have it, and that will be a wonderful solution, not just for the coronaries, but for many other anastomosis, whether it's a kidney transplant or ureteric or hepatobiliary or LVAD grafts. So we're going to be working on that also. So this is our robotic version that we are planning. So essentially the way this works, and I'll talk about that in a second. So this is like a little plunger, and this goes inside the coronary. We make a 3 millimeter arteriotomy, whether it is on the IMA or the other side. And then this guy, the second one comes in and pushes actually. So now those little hooks that you saw, they will bend upward and hold it in place. Pretty actually intricate also what design that our team has done. And so this will be now at that point completely controlled by the surgeon. And we are going to make it whereby this becomes reusable, and then the anastomotic, the device that will go actually onto the artery, it can be loaded. So that way instrument is reusable for multiple times. So it will also have articulation. So this will be a wonderful way, getting to literally all vessels, because I think what the people in Netherlands have done is kind of relatively bulky, and again is great for the open cases. I'm not so sure for the endoscopy, or especially if you have to go to the optis marginal and other vessels actually. So this will allow again the endo-wrist motions to be able to get wherever you need to. So all the degrees of freedom are there. It will have the roll, pitch and yaw. You don't need open and close in this thing, because all this mechanism will be cable driven. It's quite intricate actually, and our brilliant team of engineers, they worked on this thing literally very fast. And this is how the sizing is. This is 0.5 millimeter, by the way, it's not 1 millimeter. So it will be somewhere between 4 to 5 millimeters maximum, and it's really tiny and very, very small. So this is how basically it works. So this and this is this, we actually have custom designed this whole thing and got it manufactured also. And this gets compressed here, and this will make it completely watertight. And the little clips on the side, they go on this side, and then you just press and it snaps and you're done. And this is our the whole the robotic version. We, by the way, have filed patents, so we are able to show all of this thing. And it's quite intricate in terms of how it will be deploying and also getting these hooks to bend, and completely surgeon controlled also. This will be motor driven at the surgeon level. And this is just kind of some of our modeling. So it kind of tells you. So initially this thing goes inside, then another part inside comes, compresses on the against the wall, and also it opens up a little bit to almost 4 millimeter size, and then against the pressure the hooks bend, and same thing is repeated on the IMA side, and then you just bring the two things together. We are calling it cardio snap. So here is the mechanism here. And that's it.
Thank you, Dr. Sudhir Srivastava. It's really many days. The way forward, the amount of innovations are happening is really amazing. Dr. Balki, you can.
That's very intense design to take this device. Is this in collaboration with the Soiker group, or this is de novo?
It is de novo. I tried, and I think the big brother Intuitive has more money than us, and we don't want to waste money when we can do it ourselves. So yeah, it is not in any collaboration, and I have tried to talk to Soiker. He's not responding anymore, so I think Intuitive must have tried him or given lots of money.
Yeah.
But we'll do it, see, also they're not working on the robotic version.
Right.
Yeah.
And the patents they're open.
We have filed it.
Yeah.
Yeah.
Nice.
They filed a patent in India, and I think our IP team has researched it, and they have filed objection because of the prior art thing, and we have modified already. So we are filing our own patents, while there is an objection because of certain similarities with Medtronic. Okay, and they have literally gone through all different claims, etc. So the thing is, in India particularly, once you file objection, our court system is quite relaxed. So it will take years before this thing ever gets resolved. But no, and we are not really, we're going to be very honorable. I will still talk to him, but I don't want to delay the development. And in parallel, we are working on Nadi also.
But you were also talking about changing this whole design and making it less rigid and having some flexibility to it, which is a completely novel thing. They were not working on that at all.
Yeah. And I think this, as you and I know both, I think the compliance is a major factor, and this is where U-clips were really wonderful. And so, because they gave you a compliant anastomosis, a larger area also. So I think the way I'm looking at it, yes, that hole will be relatively, defined, but rest of the walls are still compliant. So it's not like a stent whereby it is circumferentially. So hopefully this will not be an issue. And again, time will tell. So we, of course, are going to do trials and then look at the graft patency several months down the road, and then really follow up. So again, see, because I remember that symmetry, I must have deployed 800 times or so. And I tell you, the way the thing was, it created rigidity actually, because again, circumferential. And so a lot of those venous grafts in those days occluded. And I remember that the minute the cardiologist will see that star, they know it's gone. You don't have to inject it.
Also, the angle was bad because
the angle was bad, and then of course FDA pulled it.
Yeah. And they pulled it. So the question that I always get is, why did the Seaport device fail? And why did surgeons not adopt an anastomotic device? And most heart surgeons, they take a lot of pride in their ability to sew. And if you take the sewing away from us, then we're just cardiologists. A lot of people would say. And so the big kind of unknown is, will surgeons adopt an anastomotic device? And I did some work on this. I did some digging, and I went back to the general surgeons and asked them, why did they adopt staplers for the bowel? And this is in preparation for, I think I was giving a talk as to, this was back when the Seaport stapler for coronaries was still available, and I was using exclusively staplers. And I went to people like John Alverdi, who's one of the senior guys at our place at UChicago, and some of the guys that were around when staplers for bowel anastomosis became, they were a new thing back in the late 1980s, early 90s. And what John and others told me is that it was a no-brainer, because the staplers allowed us to do bowel anastomosis without cutting somebody's abdomen, with a big incision. And I think this is where the rubber meets the road. If you divine this for open surgery, I don't think the adoption is going to be where you want it. But for surgeons to execute totally endoscopic coronary surgery, I think this is where the adoption can happen. And back when Seaport was available, TCAB was not, an interesting thing for a lot of surgeons. Today is a different day, and totally endoscopic coronary is now on the rise, or at least the interest is on the rise. And I think that's why these devices will have potential adoption.
I think the reason for the cardiac failure was, they raised a lot of money, and they blew through almost $250 million. Okay, then the price per device was high, almost like I think $1,300 if I'm not mistaken for, and then they were working actually on reusable or cartridges. I think where our goal, of course, is to not only have a handheld thing but also part of the robotic instrument, and so I remember a lot of meetings that we were together. And I know you were the largest user, and I used it also with wonderful results actually, and it did help, whereby you don't have to even place these U-clips. And I remember after the meeting, Bruce Lytle will get up and he'll ask you how much it is per, so you mean to say I have to spend $5,000 more for the anastomosis? Hell with that, my hands are good. So the ego and the pricing were the two reasons for failure. And somehow I think, although it was a wonderful technology, the business side of the company, I think, messed it up. Now, our goal, again, being in India, manufacturing in India, our pricing, if you can keep it somewhere between, around $200 or so per anastomosis, it will work, because this is a lifeline for the patients. And since it is reproducible, and levels the playing field of all the surgeon skill level and concerns, and also the speed that with which you can, do the anastomosis, and we just used to occlude it proximally only, make a puncture hole, fire, and you're done. So I think the combination of ease, and this will basically help also in open cases. And if we, we are going to work on the handheld side, detachable thing, whereby literally if somebody is going to use veins, for instance, which most people still do, they can load that thing ahead of time. Then you just connect it, and suddenly I think the op pump will pick up much, much more with that, because, you just have to reposition the heart, for a very short time. Or even if you are on pump, it will cut down your, operative time, all kinds of things. So I think there will be a big adoption if we can keep it, first of all, cost effective, and just, of course, we'll make sure that it does work in terms of the graft patency results.
Yeah, I think we'll go to the OR at Jaipur. Lalit, can you hear us? I think the ASD has been closed directly with double suturing. Yeah.
I'm audible, sir?
Yeah, audible. Please go ahead.
Oh, okay. So I think this is very clear cut to easy to direct closer. Otherwise, mostly we put a bovine patch, but this is, I think, is easy way to close. Direct closer is very small one. And here I think this is blood coming from left SVC. This here, this here. So I put this one here. So exposure definitely.
Now the suture tying is been done by the regular minimal access suture tying done by Sujit, if I am right.
Yeah, yes. How much time for this
Suture tying the knot system. I think with the robo arms we can't tie it.
Maybe sir, same or little more. I never compare actually.
You can tie, but I think it's best to use your assistant with a right knot pusher and a trained one.
And one more instrument I think the assistant was using was with what was the instrument he was pulling the knots, you are following sutures.
Yeah, this is a local made this one for
robotic instrument.
this instrument here. But one of the company, I think I
because that will help us to prevent the
yes
any further knots getting stuck anywhere. I think that follow-up was quite important when we saw that.
Yes.
So what was the suture material you used to close the ASD?
This is fluoroprolene.
Okay.
And the same for this stay suture fluoroprolene. In MICS we use 5-prolene, but in this robotic we use 4. So it's easily to handle for this robotic arm.
Any questions from the audience in the ASD closure?
About the traction of the right atrium, do you use, or sometimes do you use, or when would you use like the small mitral valve retractor, like this small atrial retractor? Like we saw a lot of cases demonstrated and all of them used this prolene fixation in the pericardium. Would you, from the minimal invasive background, so all the right atrial interventions, I use always the atrial retractor, the small form of it. Would you use, I have a similar one like this V-shaped one. Would you sometimes?
That is used normally in the my mitral valve surgeries of minimal access. In atrial surgeries, we may not use it because we need to have one more port to be, small port to be created and put in that. That can be used. Dr. Balki, you have any thoughts?
Yeah, the
Give me another side also.
Retractor. Oh, sorry.
Sir, please go ahead, sir.
The dynamic atrial retractor can be used for the right atrium or for the left atrium, but this technique is nice. As you notice, they don't have a fourth arm. So you would have to put a fourth port in the kind of parasternal area, fifth interspace, and that one comes in. You can lift up to show the mitral, you can lift up to show the tricuspid. It has some versatility so that you can focus on various areas. But this is also quite serviceable. I saw it a couple of times now this meeting, and Sudhir used it, and now Lalit. It's not a bad way to go.
Using an LA retractor for RA procedures, the RA will not just stay there. It just slips. It tends to slip. That's what we have had the experience. So it holds well for the left atrium when you go to the posterior to the groove. But right atrium just slips because there is a lot of pulling and there is a lot of maneuvering there. So RA doesn't stay there. That is the problem.
I think as he's closing the right atrium, we'll move on with the next talk. Yes, sir. Yeah, the next talk is on genetic artificial intelligence in robotic cardiac surgery by Dr. Karthik Ramesh. Dr. Karthik Ramesh is one of the AI masters, one of the top 50 AI masters in the world. In fact, on the advisory board for the royal family of UAE, currently working as a CEO in one of the Gamma group of companies from USA. I think he will take us through the genetic AI in robotic cardiac surgery. I think he is available virtually. Are you there, Karthik?
I'm here. Here.
Yeah, please go ahead. He is supposed to come. We got the information that he has just fallen 3 days back and has fractured his leg. Oh. So he is giving his talk lying down on the bed.
Yes, I'm actually on the bed.
Yeah. Please go ahead, sir.
Yes. So I hope you can see my screen.
Yeah.
Okay. So first of all, Namaste and Jai Hind, and I'm very grateful to Dr. Sudhir Srivastava.
First slide, please. You are on the second slide.
Yes.
Can you make it full screen? We are unable to see the full screen.
Yes.
It's on presenters mode.
Now is it okay?
No.
Yes.
Just do a play full screen.
You need to go for the full screen.
It's a PDF.
Okay.
You're good, we can see it.
Is it okay now?
No, no.
It was showing, like it is still on through the internet, it's not downloaded.
Do we have the slides here at our AVs?
Even now it is not visible, full screen?
No.
Is it uploaded on our system here?
Yeah,
It's not PPT, it's a PDF they're telling, is it? Can you?
Yeah, we can see it, it can be.
All right, let's move, yeah.
Let's continue. Not miss his talk, it was a great talk.
It's okay.
Do we have the slides here with us?
You are not able to see it now also?
No, no, we have the slides here. They are just putting on the slides so that.
Okay, let me start the just in the interest of time, because I don't want to take time as the screen is being shared.
Yeah.
First of all, I'm very grateful to Dr. Sudhir Srivastava for giving me this opportunity. Thank you, sir. It's always an honor and pleasure to be associated, and special thanks to my mentor, Dr. C.S. Hiramat, who has been collaborating with me in the space of not just agentic AI, but we have been working in the space of application of AI continuum across the pre-operative, operative, post-operative care, both using non-robotic and robotic surgical techniques. And I'm also grateful to Sadhguru Madhusudan Sai, who has inaugurated with his keynote today, because in his hospital, we are actively carrying out many research activities around this area of application of agentic AI. And of course, our company, which is the Gamma Group, where we are at the frontier of AI-based technologies, especially agentic AI. We're a complete AI native organization. There are several public papers which are published today, which are in this concept of application of agentic AI and the role of agentic AI in robotic cardiac surgery. Many of these are conceptual because fully autonomous robotic cardiac surgeries are not allowed. But in Frontier in Medicine paper, which was published in 2026 January by Professor Srinivasu, there's a comprehensive breakdown of how agentic AI functions in terms of creating, if you can see, how agentic AI is helping today various remote robotic cardiac surgeries over 60 network technologies, and how a group of autonomous agents would coordinate data, they will reduce latency, and they'll manage the workflow to make a remote high precision robotic surgery feasible and safe, almost autonomously, but with human in the loop. Another paper published by AI XR Cobot World Model for Clinical Perception and Action, February 2026, by MedOS, introduced an agentic world model where you bring in abstract clinical reasoning with physical world of surgery. Now, the surgical relevance of this is how do you integrate agentic reasoning with robotic control under the supervision of a surgeon, as SSi Mantra does, and how AI will act rather than a localized robotic arm or intelligence in the hardware form. How can AI act as a special intelligent agentic layer that simulates some of the physics aspects and controls it in real time, empowering autonomous robotic systems with stability and predicting certain adverse events like bleeding during the surgery. So if you look at this entire continuum, the evolution of cardiac robotics, where teleoperative is provided by SSi Mantra, moving to collaborative AI assistance in some other robots, we have seen that huge number of surgeries have been done, including by SSi Mantra, and we are moving to the agentic autonomy. You would all read about Tsinghua University in China, which has created 10,000 virtual patients with around 200 plus doctors, where the cases were fed autonomously to agentic AI. So what is being proposed here is not just a conceptual framework, but what is being proposed here is how agents can autonomously act pre-operative, during operative surgery and post-operative in terms of how they can bring in certain enhancements to the surgery. If you can go to the next slide. So you look at the SSi, the case study which I recently published also called the algorithmic heart. Let me give you an example. SSi Mantra, as all of us know, has performed several minimally invasive CABG procedures. If I propose, if we infuse agentic AI, what if the robotic arm can autonomously control, and with this facility, it also brings in micro motion at sub-millimeter level resolution. For example, let us talk about Lima to LAD anastomosis, right? So it will rely on certain physics-based calculations. For example, force, torque sensors, haptic feedbacks, using what we call in AI machine learning, Bayesian active learning. In real time, the robot itself will perform in semi-intelligent mode in localized areas to ensure, for example, tissue compliance, or it will help to drop, the patency failure rate significantly. Also, we have seen that, material valve replacement, even in this conference, you've seen several cases just now. Scaling such complex procedures with agentic AI and neural networks. For example, if we can integrate this real time with the SSi Mantra console, you have another console, which is an agentic AI agent, which is an autonomous agent, which is analyzing 12-lead interoperative ECGs, and it can predict real-time arrhythmia onset 30 seconds before any such clinical manifestation happens. Even in complex valve manipulations, the agentic AI screen will prompt, and I'm not talking about humanoid, I'm talking about a software-based agentic AI, which is independent of the robotic surgery to prevent any, risk overrides in the surgery, which will prompt the surgeon and also assist the SSi Mantra or similar robotic surgery arm to reduce tension and alert perfusionist, without, having manual surgery inputs. Another example could be in complex ASD repairs where we have multimodal sensor fusion, where in very delicate procedures, for example, let us take atrial septal defect repairs, and how agentic AI will fuse pre-operative 3D CT scans. So the console, which is running independent of the robotic arm, is operating through a software agent, which is building real-time the reconstructions of the 3D CT scans. It is also combining this data live with fluoroscopy and intraoperative TE and synthesizing a surgical situational awareness. It is simulating the surgery real time using the software which you're seeing on another screen without distracting the surgeon. And with this kind of an integration of agentic AI, where you're bringing in pre-op scan, you're improving the fusion accuracy, and you're able to deliver even under 50 ms latency. But towards this, today, I live in the UAE where the vision is 2020 to keep the human in the loop as is the medico-legal laws. We'll have to have sub-second safeguards if any such agentic action is executed. We should have reversibility within 200 ms, either via voice command or via, foot pedals. We'll have AI restricting some of the, if I can call it pre-surgical fences, the agentic AI. So there are certain no-go zones which are alerted real time by the agentic AI. Of course, we'll have to look at as we democratize and bring in some of these things, which as I told you right now is mostly in the conceptual theoretical framework. But if I can integrate some of the pre-operative, operative, post-operative monitoring intelligence using agentic AI, along with, as I said, 3D pre-operative scans, along with, maybe a live endoscopy feed, and continuously receiving signals of the vitals of the patients, both from SSi Mantra as well as other intelligent interoperable machines in the surgical theater, we could lead to, I would not say autonomous, but I would say a largely semi-autonomous assisted agentic AI network. So this was a case study which we had done. It was also published as a paper by Dr. C.S. Hiramatha and myself. As I said, some of the legal challenges are this. Lastly, just in the interest of time so that we could have some time on discussion, I'd also like to quickly, I'll share the screen now. If you look at, we are also bringing in through, our company is bringing in avatar-based, Dr. Sudhir Srivastava just spoke about humanoids. But with agentic AI, we are also able to create, for example, I could create Dr. C.S. Hiramat's avatar using our Pranic AI platform, integrate this with the agentic AI. So there is almost like a live virtual avatar, which is assisting the surgeon, talking in real time, receiving also commands real time from the doctor, and helping, assisting him, as I said, with the preoperative data. which is already available. So just in the interest of time, I'm stopping the sharing. And my apologies that I could not come in person and literally do this from a hospital bed. So we are looking at how, as I said, 2030 vision of countries which are very forward looking. It's great to see SSi Mantra make great strides of Make in India and the global impact they are making. But in line with the vision 2030, how can we integrate agentic AI, work towards outcome-based excellence, and also create value-based care outcomes both for the care provider as well as for the patient, while we ensure regulatory, ethical monitoring and ring-fence this within the ethical AI framework of agentic AI. The only last footnote I would like to make in this conclusion, when will this happen? So the research world, the academia, which is working on agentic AI, we as a company are trying to create the world's first agentic AI hospital, virtual hospital, I should say, in India. This vision will become a reality sooner than later. But our prediction is somewhere in the year 2030, we would get to more autonomous, agentic AI agents, which are both virtually as an avatar, as a software, and possibly even as an additional presence, robotic presence in the surgery, in the surgical theater, helping the surgeons achieve greater outcomes. And we look forward to also working with SSi Mantra on the synergy to make this as a force multiplier, where especially in resource constrained hospitals, if an agentic AI can help fill a human resource gap, or in some of the teleoperative surgeries, if there's a local AI, agentic AI agent, which is, acting on the behest of the remote surgeon and working in tandem with the SSi Mantra robot, we'll be able to do that. Another last application I'd like to mention is post-operative care, educating the patient on follow-ups, and how do you get into multi-step post-operative consultative sessions, and how do you improve the literacy, health literacy? That's something which we're working again with Dr. C.S. Hiremath in Sri Madhusudan Sai Institute of Medical Science and Research. How do we educate the patient on and engage in active follow-ups using virtual avatar-based agentic AI post or robotic surgery? And I think the new combination is going to be a supercharging of SSi Mantra's new remote capabilities, along with the battlefield capabilities of agentic AI. And how can we, for example, as I said, a surgeon in a teleoperating scenario work with a live agentic AI, sieve through the chaotic medical records, preoperative scans, and also working as a crisis manager, an additional crisis manager, and a third eye to the robotic arm which is involved in the surgery. And given that SSi Mantra is an open platform, we look forward to integrating and doing some of these proof of concepts in the coming months and years. Thank you very much, Jai Hind, and thank you for this opportunity.
Thank you, Dr. Karthik, for taking us through this agentic AI. Dr. Balki, you have any questions for him? Sounds very interesting and difficult to understand, at least for me. So I request Dr. Balki.
Yeah, this is definitely next level type of robotic surgery. First of all, it's great to hear your talk.
Karthik, we can't see you. Can you?
Am I visible? Yeah.
And
they have to share me on the screen. Yeah.
And thank you for persevering and doing
Sounds
your
like
talk.
it's moving fast.
Yeah.
So I guess there's a lot of different issues that come up. I think you addressed the ethical. There was a paper that was published in 2023 in JTCVS Open that you were referring to. What was the override? How was that arrived at? I think the quote was 200 milliseconds, the human override in case of any kind of need to take control. How do you arrive at the timing, and does it vary between different cases or different scenarios?
Yeah, absolutely. So what happens in these scenarios is we'll have to kind of it's not happening. Agentic AI is not necessarily working in a live surgery case. We use 3D simulations, and we use what is called as augmented virtual reality, where we feed in the data to the agent prior to the surgery. So even before we come to the operating table, we take the virtual patient data. So we literally create a virtual patient using the agentic AI. We feed in the parameters of the preoperative scans. The entire surgery is simulated at an agentic AI world level, where you basically define what are the possible scenarios, what are possible worst case scenarios, fail safe scenarios, And when you bring in the data and when you try to do this in a simulated AR VR environment, you are then able to simulate, as I said, these 200 ms latency issues. You are able to look at various workflows and, therefore improve the precision. So you're actually kind of pre-educating an expert robotic cardiac surgeon prior to the procedure on how, the outcomes could go and where they could go. And on the 200 ms latency reduction, what basically has to happen is, we'll have to, as I said, continuously live feed some of this data and make sure that, there is a real-time decisioning which is happening along with, the surgeon's, physical control and the robotic arm.
Very nice.
Dr. Sudhir, your comments on.
Sure. I think it is going to happen. We will absolutely love to collaborate with you, Karthik. I think there's a huge opportunity, and it's only human imagination as to how far we want to take it safely and effectively. And there are a lot of things that I think can be actually automated as parts of the procedure, not the whole procedure. I'll give you some examples. IMA takedowns, for instance. We talked about do virtual surgery on that one, register every single thing. And of course, we'll have to go through a whole bunch of trials, because the minute you introduce the word automatic, the regulatory bodies go nuts. And it must also be absolutely taken with very serious responsibility, because again, do no harm. And the fear of robot operating on you psychologically, and the patients will stay for a very long time. Okay, and right now, even when we start to tell people that I am actually controlling the robot, it becomes different versus the rumor mill or people who don't do robotic will tell patients, oh, but you don't want machine operating on you. So I think where it can become a collaborative effort, also certain tasks that with the computer vision, whereby you don't have too much variation. Take an example, let's say you feed mitral placement of sutures. Once you have done whatever surgically, either you cut out the leaflet or preserve, whatever it is. Now you have a circle there to place sutures. The machine will do much faster than the human. And especially the thing that what we are developing, and also bringing of supplies, for instance, so I think there will be areas of collaboration whereby it becomes like more of assistive initially, and then actually primary operator. But gradually, I think if we can get through that this phase, and it will require tremendous number of things to be done before we actually get it into a patient. And yes, it is all possible. And yes, at some point when we have quantum computing and all that, a really routine part of things, things will be different, but we are not there yet actually in real time. Because if you look at the quantum computer, it is huge, and the things will change. But I think we can really at least work towards that. And will it replace the manpower? That's always the question comes. I think, just think about it as a surgeon. When you have an assistant surgeon or as another surgeon, it's a pretty boring job for an assistant surgeon. And if you don't have a trained PA, what they're doing things that somebody else can do it once trained. So I think those are the things that I think we should kind of gradually look at. And in fact, in our setup, we are trying to really create a completely separate team for AI and ML, and then give them tasks, and then, experiment. We have already done, whereby pick and place exercise, for instance. Our engineer sat and he did that. We registered all the motions. He got up, he pushed the button, and robot went to work. So yeah, is it doable today? Yes. But I think we need to do it in a very serious, responsible way, whereby, because if we cause problems, I know if you look at Tesla model, for instance, they've had accidents. all kinds of things have happened. But nobody will forgive us, and the lawyers definitely will not, if we do something that causes harm to the patient because of what we walked away from traditional approaches.
Yeah, Karthik, I have a few questions. Can this genetic AI in the coming days help us to guide what is the optimal port placement for a robotic arm, whether it's a mitral valve surgery or a ESD surgery or a coronary surgery? Can we do that?
Yeah, as Dr. Sudhir Srivastava rightly said, Dr. C.S. Hiramis, it's a great question, but as he said, rightly said, we'll have to try some of this in very controlled, non-critical use cases where we should use, as I said, virtual reality. We should try to simulate this, try it, but is it possible? Answer is yes. And I would also like to request that, Dr. Sudhir Srivastava, we would love to partner with you as a group, Gamma Group of companies. Our chairman, Prasad Gundumogla, who resides in Silicon Valley and Texas, along with our group CTO Kiran, we would love to come and we would like to facilitate working side by side with your AI/ML team. I just wanted to mention that before I forget. Next question, sir, Dr. C.S. Hiramis. Yeah.
Can this robotic AI help us to select a case also subsequently based on the history taking what you are recently working on the history taking part? Which case can go for a robotic surgery?
Yeah, I think that's a great question, sir. Yeah, that is a perfect case for agentic AI. We can feed in all of the data of past cases and we can actually create a virtual robotic surgery environment where, let us say, we take 200 complex robotic cardiac surgery. All that the surgeon has to do, we don't even need the case data alone. During the surgery, if the surgeon can keep talking, our software, Pranic Agentic AI, can hear to these conversations, record that, transcribe it, analyze it, and as you rightly said, we also have ability to correlate it with the past records and predict future outcomes or predict better interventions in the future. So that is very much possible, sir. Yes.
Can this agentic AI, when we do coronary anastomosis using a robo, can it tell us whether the suturing is competent, correct enough, or have we done some mistakes, something like that? Because it's quite challenging using a robot.
If you take the videos from various such anastomotic procedures over a period of time and say range of complexities, I would not advise to do any of these things, as Dr. Srivastava said, in a live case till it is all tested, established. But can we take videos and can we process it using large language models and look at better ways, for example, to do this with higher precision and better latency? Answer is absolutely yes. Today it is possible, but post-operative based on some high precision videos and case data which we can collect.
I think we can do a collaboration with Dr. Balki, wherein regularly coronary anastomies are done. Sir, with the videos we can come up with this technique so that we can set standards of a robotic coronary anastomosis.
Yeah, and that is one way to automate what we already do in terms of suturing. So we're automating the suturing technique instead of creating a device. But Karthik, can you compare this to what is already being done in terms of autopilots? I know Sudhir talked about Tesla and the accidents, but how about things like Waymo and other types of automatic driving cars that are already on the streets? The variables that are taken into account in the calculations in that seem to be much more diverse than what human anatomy would potentially present.
Yes.
Can you speak to that a little bit?
So Waymo, Tesla, all of these, when you talk about autonomous vehicles, that is a terrain which has been researched and studied. You have so much of data over the last, I'd say, almost 2 decades before it was perfected. While some of these companies like Tesla would have accelerated the science to technology part or the technology to innovation. So you spoke about real-time analysis of scenarios or, the environment. But MIT in the US, I would like to make a remark here, did an interesting experiment called it was a model experiment, right, where they simulated when cases of accidents happen, or let's say a pedestrian crossing and autonomous car like Waymo or whatever, like Tesla goes out of control. And let's say there are different age groups on the road. Who would that autonomous vehicle which is out of control go and hit? They actually trained this. So it is not just about the real-time parameters which have been mastered using deep vision, convolutional neural networks and various other AI/ML techniques. Because if you look at it, even literally from a Tesla's angle, you look at the dashboard, the AI dashboard, all it sees as a human being is a red piece of infrared. It is just seeing it as a blob, a piece of flesh. It is not seeing it as a woman, man. It is not seeing it by gender, age. So MIT started this model experiment to train AI in cases of emergency or accidents, it should ultimately not cause any harm as per the 3 law of robotics. But given a moral dilemma, where should it go? So I think even the autonomous vehicle industry, while it is doing a great job in navigation, we do have accidents there also. But that is a field which has matured over years. But companies like SSi Mantra and all of the other, companies which are their peers have, they have come in over the last decade or more. We'll have to perfect, and the complexity and the range of error is very, very less when it compare it to an autonomous vehicle's, path. And that is easier to predict because, as I said, you can always detect a human being or a living being versus a bus or an other vehicle, which is non-autonomous. But here you're actually dealing with a life. So there is some way to go on that. But short answer is yes, it is possible that we can achieve a greater level of precision. But that is precisely the reason why countries like China are investing in agentic AI-based autonomous hospitals, where you're simulating this in a controlled environment, and then you're retrofitting it into a real-world environment. So we could do similarly in robotic cardiac surgery, take 1,000 cases, simulate it, and then see how it would operate in a real-world environment in controlled situations.
I think where a lot of this will help in terms of the whole pre-operative planning side of things,
yes,
beyond port placement, those are very easy. You feed the 3D imaging data, it will tell you exactly what trajectory the instrument need to go,
yes,
based on that in the external environment or the body where you need to place the ports. But also you take example of mitral repair, okay? We now have images, so if you feed all kinds of images and various types of things that apply to this thing, and now you have patient-specific data, imaging and all, other things, it will tell you what repair will work, okay? So we, see a lot of times, and I've seen surgeons, including Carpentier, who spend 30 minutes evaluating the valve, what to do before he starts, okay? So we can see where the time is lost when you don't know what to do. If you know ahead of time what to do exactly, or in a coronary anatomy, where are you going to make the arteriotomy? Although we have looked at the angiogram and all that, but if you have the CT, all this data, where the plaques are, would you be able to put the shunt in there if you make that incision there? And we have seen that in my own cases. You think that, you'll be able to put shunt, and right there is a plaque that was not seen. And now you're stuck. So I think a lot of these help actually, not only, I think in guiding, but also guiding us in our operative conduct that we know ahead of time. So then the whole thing becomes easy and efficient. And then of course, ultimately you need to, you feed, let's say, 1,000 videos of IMA takedown, which will have all kinds of variation, variety, so on and so on. Human intervention, of course, must be available, but you now have a resident doing the takedown. Or in telesurgery particularly, you can have this thing, automated, and surgeon doesn't need to be there to finish the rest of the operation. So there are things I think we will need to look at in a very intelligent, but keeping the safety in mind most importantly. And yes, is it doable? I think it will be. And I think we'll be very happy to collaborate, Karthik, and
yes,
let's plan out that sooner than later, because time is of essence in our SSi
yes,
team.
One last question, Karthik. Just can this genetic AI coming to research part, can it help us to compare or build up a steady protocol to compare certain surgeries like traditional mitral valve repair versus robotic mitral valve repair?
Absolutely, sir. I think you hit the nail on the head. I was about to tell that when Dr. Sudhir Srivastava was talking just now, that in training and building better robotic cardiac surgeons, this is going to be a huge help. again, just based on, processing some of the pre-operative, operative conditions, tracking all of the videos and actually telling agentic AI to build a language model. And that is, sir, one thing we are doing, as you know, in your institute, to build a cardiac large language model, cardiac small language model. And we will work on even robotic scenarios where we can distinguish between various complex procedures, as you just mentioned. And we look forward to building at least a Tesla level autonomy, Dr. Sudhir Srivastava, in a controlled environment. And we will look at, how we can work together on this. We'll be very happy to sign an MOU and work. Thank you for the opportunity. And apologies for my posture because I'm literally lying on a bed and doing this session. So thank you very much again for having me here.
Thanks, Karthik. It was wonderful. Yes.
Thank you, sir.
Thank you once again. Yeah.
Now, I've got a couple of announcements, guys. Here, first of all, before we leave the room, we are getting some photographer.
I'm audible, sir.
Yeah. I think Lalit Malik, I think the case got completed. He wants to make his final comments. Yeah, please go ahead, Lalit. Yeah. Okay,
I think we have done already. This is there is no bleeding here or aorta. And if you want to check this T, then no air, and we close this ASD.
Yeah, what I saw was you were little putting additional sutures at the site of the cardioplegia site, and I think you were using some gauze pad. What exactly does it help us to?
This is
some compression or what exactly it was?
No, sir. Sometime blood is come out the camera. So this is only this is we make this is called cigar, and this is very small one to check the bleeding.
Okay.
And sometime if blood is come directly to our camera, so that time no vision. So we stop this bleeding. We hold between this bleeding and camera. So this prevent our.
Okay, because here on the vision we thought it was
this prevent our vision actually.
Because the camera is looking straight at it, and the spurt will hit it, and now you have to take it out while it keeps bleeding. So I think this is a great technique. Or sometimes I just grab it with my needle driver, the two pledges, and keep it there. I put my foot on the clutch, and it is frozen.
Okay.
Yeah.
Okay.
So I think is done from my side. I think okay, sir.
Great job, Malik. Great job, Malik.
Okay.
Thank you.
Thank you so
Thank you.
Thank you so much, sir.
Yeah.
Thank you.
We'll paste you in the picture using AI. All right. So we'll get a picture of all the group. Also outside, we will go towards the entrance, and in front of the building there is a Nataraj statue. So all the delegates, we are organizing a picture for memory. And also, I really encourage you, please walk through our experience zone. And Sam, I'll take you personally. I think it is phenomenal. It will give you also kind of visual as to what we are doing in some of the futuristic ways and ideas. And also, always open to really receiving help. I know these are the conversations that help us to evolve or create things that will be helpful in our procedures. So please reach out to us. And also later today, starting 5:30, there's a wonderful cultural program organized in the big hall, which is going to be the gala dinner. It is Rajasthani Mast Kalandar group that is coming. I'm from Rajasthan, so I thought this time we'll create a change. And also Rajasthani dancers. So from 5:30 to 7, we'll have the cultural program and then open up for dinner. And this time we decided to do it this way. Firstly, there was a gap. Secondly, many times you have the gala dinner going at the same time as the performances, and nobody pays attention. So these artists also deserve respect, so we decided to do it a little differently and, and fill the time gap also. So please join. And so, Avinesh, can we get somebody from the camera side, and let's gather over here on this side. Let's get picture. So thanks, Lalit. And
thank you, sir.
We'll sign off from you.
Okay, thank you, sir. Thank you so much.
Let's also please give a round of applause to our chairperson, Dr. Ajay Cole, and the moderators. Please gather to the front so we can take a group picture, and then we'll be exiting the summit room. Thank you.
Yeah, please come on over this side, everyone. Sure. This side? All right. Back. No, no. Come on, guys. It's not that bad. Yeah, let's go out first. No, at least one after that, I think we can, because the others all, this session. So everybody will get together. So we'll go towards the entrance and then after this,
after that, we'll get started with the cardiac session for afternoon for day 3 of SMRC 2026. Thank you very much.
ब्लॉक दिखा रहा है प्रेशर कितना ज्यादा बीपी क्यों ज्यादा है
प्रेशर ज्यादा है थोड़ा कम करना
बीपी थोड़ा सा कम कर लो पहले एक सेकंड
हम उसके साथ लोग
हो जाएंगे ठीक है चेस्टल दिख ही नहीं रहा है कॉन्फ्रेंस के लिए केस नहीं है ऊपर वाला पोर्ट डाल सकते हैं क्या हम इसे इसको तो हमें छुटाना पड़ेगा ना किसी तरीके से पोर्ट डाल के ना तो निकालो इसे
नहीं
कॉर्टरी ना तो लाइट देना इसमें है ना नहीं उसे बेटर है इस पोर्ट में अगर हम डाल देना बट पहले नहीं इतना देखो सर क्या दिखाना चाह रहे हैं यार इसमें अगर ऊपर वाला पोर्ट डाल लेते ना, देखा ना? हाँ हाँ, एक सेकंड, एक सेकंड देखा। थोड़ा सा दिखाना, हाँ दिखाना, इट्स कमिंग, एक सेकंड दादा, दादा देखना कैमरा, दादा हेल्प करना। तो से बाहर निकल।
It's on now.
Both the ones are on.
Yeah, this one. So camera clean करो।
Dr. Saxena, I'm Dr. Abby, Director of Medical Affairs.
So we are online?
Director of Medical Affairs, SSi.
Huh?
Dr. Abby.
ठीक है, ठीक। ये अंदर है ना? हाँ। ये है ना? देखते ना। हाँ, करो। एक सेकंड।
Not surgical.
Listen. मेरा ऑडियो ऑन कर देना एक सेकंड।
ऑडियो ऑन कीजिए ना।
जरा देखो। Who is there? Dr. Srivastava is there? Yeah.
Hello, Dr. Ritwik. Dr. Sudhir is on his way and will maybe in about 10 minutes or so.
Yeah, that's all right. We are just putting the ports. Thanks. Bye.
Yes, you can go ahead and get started, sir. Thank you.
Thank you. Bye bye. Namaste. Salam alaikum. ठीक है ना? And this is a very important video for all of us to do this thing, and then the Mondal maneuver to the bigger thoracotomy. Mondal's fingers are better. Do this. Sure.
Hello, Dr. Ritwik.
Yes.
There are too many adhesions, no?
Yes, ma'am. We are stuck.
Dr. Manju, yeah.
Hi, ma'am.
Dr. Manju Gupta from Safdarjung.
Yeah, ma'am. I understand. Thank you, ma'am. Thanks for attending this. Yeah.
Yeah.
So this is a typical,
Yeah, there are too many adhesions.
The typical conference case.
Yes.
Okay.
This is called the curse of a conference.
We are trying to release the adhesions by lot of things.
One more thing, will I said both of things will be in the multispecialty the last division and then can you do me a favor?
ठीक है? तो ऐसे देखना, ठीक है ना? दादा एक काम कर सकते हैं, इस पोर्ट से ना इंस्ट्रूमेंट घुसा के ना we can take out all the adhesions up first. बाइपोलर कॉटरी स्पेशुला कॉटरी
स्पेशुला तो जब तक ये ऑन नहीं होगा तब तक नहीं कर पाएंगे कर पाएंगे
yeah we can
camera or the
yes
if the one is one
that's what I'm saying and then dissect the whole thing yeah so am I audible?
Very much so.
Yes.
Thank you. So it's so much of dense adhesions. What I am planning to do is to put the right instrument first, and then release the adhesions, and then put the lower part.
Dr. Ritwik, this is Dr. Saxena.
Sir.
Can you hear me?
Yeah, I can hear you, sir.
Now, all of us have had a very good lunch, and we are in the mood for a postprandial siesta. Now, you have to keep us awake. To me, it looks like you're looking down a well, and the lungs are very bad, looks like a heavy smoker. And
sir, I think you are still very awake and up. So, but in the meantime, we'll just brief about the case.
That'd be good.
He's a 66-year-old male and diffuse triple vessel disease. And but unfortunately, when I am looking, because he is the only case today we have, being a Saturday. So when I look at the angiogram, I don't think we'll be able to put bilateral memory. We'll try to see whether we can harvest the memory anyway, but he doesn't need bilateral IMA because he has got a very good LED and the rest of the vessels are very small. So I don't think it will be a good idea to do a lima Y and put and jeopardize the lima to LED. So in that case, most likely I might just go in for a single memory, but whatever it is, I'll be very fast and try to show it because at this stage we are stuck up with a lot of adhesions on the lungs. We're planning to do one single port and see how much adhesions we can release.
well, we go by your judgment, and whatever you can show us, the tricks and trade of the trade, we'll appreciate it.
Yeah, so in the meantime, I'll hand over the mic to our anesthetist, Dr. Neeraj. He's a very senior anesthetist at Fortis Escorts, and he'll just brief us about the ventricular function, the echo. We can show the echo, and also he just briefly tells what is our protocol to have pain management and anesthesia in general. Over to Dr. Neeraj.
Just out of interest, I would like to know, with a show of hands, how many of us have been interested in robotic or done robotic takedowns among the small audience that we have? Can you raise your hand?
Sir, I missed that.
Hi, good afternoon, everybody.
Good afternoon.
This is a 66-year-old patient. He is diabetic for last 15 years, and he has a history of angina on exertion since last 2 months. On last Saturday, he had severe chest pain and visited hospital where angiography was done, which shows triple vessel disease. So our anesthesia protocol is in a robotic cardiac surgery is a single assessment for the lung function because we have to occlude one lung. So because the idea of robotic surgery is fast recovery. So for that we usually give some different things for pain management. In our institute, we usually give intrathecal morphine, little bit of morphine, 300 to 500 mics, intrathecal morphine. And rest of the things, we induce the patient as per the standard anesthesia protocol. And as far as the monitoring is concerned, we put invasive arterial line and PA catheter and echo, transthoracic, transesophageal echo in every patient. So we induce with the standard anesthetic drugs and maintain anesthesia on inhalational as well as on continuous injectable dexmedetomidine. Is there any question for? Hello?
Yeah, I think
Am I audible?
Yeah, you are very much audible. Please go ahead.
Yeah. So in this case, the LV function is a normal LV function with a little bit of MR, mild MR. It's a mild MR. Rest of the heart function is normal. Can we show the echo? Huh? Focus होगी. This is a 4-chamber view where we can see the good septal as well as lateral wall movement, as well as normal anterior wall, inferior wall, and anteroseptum. So he's having trivial to mild MR in different views.
What is his PA pressure?
The PA pressure is right now is 35/18.
So that's not much of an MR then.
Yeah, it's a trivial to mild MR.
So, Saxena sir, Dr. Ritvik here on this side, and so I think at this stage you can start your talks on the seminar hall.
Okay.
And I can dissect the lungs from the chest wall, and by the time we are done that, then we'll come back to you. Give me about 10 to 15 minutes time, sir. Thank you.
Is he a heavy smoker?
Yeah.
Yes.
He is a heavy smoker for last 20 years.
Yeah, the lungs look bad.
Yeah.
Okay.
It looks like a normal Delhi lung, sir.
In Delhi, you get 1 pack complimentary. Anubhav? Ma'am? We have 10 minutes. Can we keep on talk?
Good afternoon, ladies and gentlemen. Welcome back to the afternoon session of the cardiac track of Day 3 SMRSC 2026. I would like to take a quick moment to introduce myself. I'm Dr. Abrami Babu, Director of Medical Affairs at SSi CRS. And joining us live from Fortis Escorts, Oakland, New Delhi is Dr. Ritvik Raj Bhuyan with a live transmission of a possible Lima takedown. Let's also welcome our chairperson for this session, Dr. Devendra Saxena, with a huge round of applause. We can do louder. We can do louder. Okay. And as for our moderators, it will be Dr. Milind Hote, Dr. Vivek Javali, and Dr. Gokhale, who will be joining us shortly. And I believe with just us getting started with the live transmission, we can go ahead with the presentations as directed by Dr. Saxena. So for this, I would like to invite Dr. Anubhav Gupta onto the podium to present robotic cardiac training of residents in a teaching institution.
Anubhav, please go ahead.
So, thank you, sir, and thank you, SSi and Dr. Sudhir for inviting me. So, the lecture which has been given to me is Robotic Cardiac Surgery Training for Residents in Teaching Institution. This is a little bit of a different topic because as you see, we are all cardiac surgeons who are training in robotic cardiac surgery. So what is there for the residents to learn? It's what I have to talk about in my talk. This is the place where I work. This is called the super specialty block. It's a 900 bedded facility, and we have our robotic system on the second floor, and our OT is on the first floor. So I've tried to divide my talks into what are the learning pathways in robotic cardiac surgery, what does the STS and the EACTS say. I have tried to exclude the slides which Dr. Balki presented yesterday. So this is going to be a complementary talk on learning pathways and what there is for residents. And what are the learning pathways for robotic cardiac surgery in India? Our group has looked into what can be the possible learning pathways in India. And then I will dwell upon a little bit upon what is the resident training program in robotic surgery world over and where do we stand in India. So this paper came out from a lot of surgeons, and one of the co-authors is sitting amongst us. So this was an invited expert opinion in which most of the active cardiac robotic surgeons came together, and they published contemporary robotic cardiac surgery training. So it's basically tried to say that for last 20 years the robot has been around. So what should be the situation? And this publication was in JCTVS in 2023. I'll just go through what are the salient features of the consensus statement or the expert group opinion upon the training in robotic cardiac surgery. So this paper delineates two lines of training, which in US is defined as a robotic revascularization program and a robotic valve or an intracardiac program. So you need to have a separate set of skills, a separate set of prerequisites to get into the program. And in US, basically, most cardiac surgeons have decided to be part of one program or the other program. So you don't see a lot of people who are doing both together. Although there are people who do, the stalwarts are doing both of them, but the newer people, they are asking them to either choose this program or the other program. So when we come to robotic revascularization program, so it says that the person should have 3 years of independent attending level clinical practice or at least 1 year postgraduate cardiac surgery fellowship. As far as clinical experience is concerned, 250 cases of coronary revascularization as a primary operator with an operative mortality of less than 1% and at least 50 off-pump CABGs in that. Institutional resources, 250 cardiac surgical cases per year for a minimum of 3 years. A dedicated team of institutional-based cardiac anesthesia who are very good with TE, and then a group of perfusionists and institutional access to advanced medical support. Coming to the other wing of robotic valve program, so again, he should be an independent consultant or at least had done a 1-year fellowship in cardiac surgery. 75 career mitral valve repairs and replacement with less than 1% mortality, and out of those experience, at least 50 in last 2 years. So basically, you must be an independent surgeon who is doing good volumes, and then you should dwell upon coming to a robotic program, or you must have done a fellowship and then you are working in an institution which is high volume. That's the summary of what has been said about this learning pathway in this thing. So it again talks about robotic revascularization programs. It said you should start with doing an ITA harvest. Then you should go to then heparin administration for ITA fixation to the pericardium, then a mid-thoracotomy, mid-cab or a T-cab, and then LITA clamp release to closure completion. Then these are the basic step-by-step to robotic revascularization or valve surgery, then skin incision to heparin. So these are the timings you actually need to note for everything. You must understand what time are you taking. So your operation should be divided amongst these headlines. So you must see that after doing the LETA harvest to what is the time you have taken from LETA harvest to heparin administration. Heparin administration to LETA. So every surgery has to be subdivided into various specific tasks and timing, so you can look at it and improve. Then skin incision to heparin, cannulation initiation to cross clamp, initial atrial incision to mitral valve exposure, first annular suture placement to a completion of ring or prosthetic release, or a first aortic closure suture to completion of the atrial suture. So you must divide your practice into a step-by-step and then do the debriefing with these points. Then initially we didn't have a certified fellowship program in US, so we had two groups of training. One was a industry-based training or the intuitive training, and the second were the fellowship trainings. So once you look at the intuitive or that training, they said on-site technology introduction and training, which they used to call it a test drive, case observation and peer-to-peer interaction, skill simulation, then skill drill, and on-site assessment, and then extensive simulation sessions with docking, troubleshooting, etc. Basic training in pelvic surgery in animal models, and then advanced training, which is international, either in Korea or in US, wherever, where you go and spend 2 days at least in the training. We also looked at what should be the credentialing and training, because in India there is no credentialing. I can today call myself a robotic cardiac surgeon. So what is the credentialing which is required? Can anybody call himself a robotic cardiac surgeon, or who looks at this credentialing? So who is qualified, who is not? Because somebody who is not very, may send a very bad name to the program. So we also looked at this from our institution, and we decided to divide in 3 levels. So first was the classroom, which is the level 1 training, in which you understand the robotic technology, do a basic troubleshooting, and look at the limitations. Then individual procedures like patient selection, procedure indications, and preoperative workups. Level 2 were what you do on the console. You do a dry lab, then you do a wet lab, and then you do virtual reality simulations. And then we divided that into a part 3, which is called the clinical, which is patient positioning, port placement, assistant and working port maneuvers, operating under supervision, and then doing individual cases. We also looked at what are the different description trainings and the pathways where you can learn camera control. So if you go in a simulator and you are working on a simulator, so these are the subheadings you need to understand. You must be able to do properly control the camera, so you can rotate the camera, you can zoom in, you can zoom out. Then energy control. Once you are using energy, you should be using it in the correct form, like a monopolar or a bipolar, the left instrument or the right instrument. So these are called the energy control exercises. Then the endo-wrist manipulation. So when you're doing endo-wrist manipulation, you are able to move have all the freedoms with the endo-wrist instruments. So you have 2 types of training with that. And then the 4th arm control. So you need to have a very good practice of switching. If you're using 4 arms, at any given time you can only control a camera and 2 arms. So you need to switch arms. If you're doing 3, that's not a problem at all. Then needle driving advancement, and then you can always practice needle driving and other aspects, and vertical closure, horizontal closure, 2-layer closure, and single-layer closure. Then we also, in our paper, looked at what are the different fellowships which are available all over the world. And we also gave the links of the fellowships which are available. So these are one of a few. And now in India, we have started our own IACTS robotic fellowships. So that is happening at 2 centers. And that is something good news for us. Our association has taken up this challenge of having 2 accredited fellowships. But this fellowship is getting a certification from IACTS. It is still not a certification. Ideally, there should be a board certification. We don't have that system in India. So once you have a degree, you are qualified to perform a surgery. There's nothing called a board certification in this country, and I think we need to move, and we are moving towards a standard, because somebody may be trained from a very high volume center and he may be more competent. So a competence-based board certification, I think we need to move up in this country. Then we also looked at, are there any published literature about resident training in robotic cardiac surgery? So we got one of these papers from China. And it said that during residency, how can we prepare our residents for an inevitable future? So this was published in 2022 in Laparoscopy, Endoscopy and Robotic Surgery Journal. So basically what they were trying to talk about was what are the programs. So they looked at various different programs which are available in US, and you will see that most of these programs are directed towards experienced surgeons. And there are 3 programs, if you see in the list down, that they are for the residents. So they are the only 3 programs in which they give permission for training for residents. So they also define what should be the resident training in robotic cardiac surgery. So they said implementation of a simulation training. So if you have a simulator with your robot, you practice on that simulator. Then you need to establish wet labs and dry model training labs. And I think India, we are lacking a lot in trying to establish and dry and wet labs for our cardiac surgery trainees. They don't have any exposure to dry and wet labs, and we need to work on that. Then introducing skill proficiency, objectives at determining stages of training. So they said that you should start with a lima harvest, do a pericardiotomy, then do a ASD closure, and then you can go for an annuloplasty. Then increasing resident participation and involvement robotics. So if you train them from the very beginning, it makes life much easier for them once they become attending consultants or faculty. And if they want to, once they have a good peep-in, they may decide to have a career in trying to become a career robotic cardiac surgeon. Then increasing, then all residents should at least get exposure in simulation centers. So we may not have a robotic program, but we have still robotic simulators which should be available. And if you don't have, we can send our residents across to various places where the training is happening. I know SSi has also opened a training place in Gurgaon. So most of the residents in their training should be sent to a center where they at least are exposed to what a robot is, how it is docked, and what are the various nuances of a robotic program. There are only 2 large robotic cardiac programs in the public sector, and one is Safdarjung and one is SGPJ Lucknow. And it is quite unfortunate we don't have a lot of public sector places where robotic cardiac surgery is actually happening. So we also looked at what do we do in what has been our experience for last 4 years in trying to teach residents. So what we have been able to teach residents are in protocolized workup of patients to decide candidature for robotic surgery. We must all understand that all patients who are coming for cardiac surgery are not candidates for robotic surgery. If you choose our patients well, we have a protocolized system for working them up and then deciding their candidature. We had a talk earlier of AI looking into it, how to decide for candidature. Then patient positioning and OR checklist. So any checklist makes a lot of life much easier. You go in all of us sit in in aeroplanes. Every day there is a debriefing on safety. We must have taken thousands of flights, but still we have to listen to what the debriefing is. And these checklists have come actually from the industry, the airline industries, and we have the WHO safety checklist. And so in our institution, we have a lot of checklists for a lot of things. Then we need to teach the residents how to have a safe establishment of CPB via peripheral cannulation, because that becomes the bedrock for doing minimal invasive and for doing robotic cardiac surgery. Then they should also understand camera handling and port placement. See, the problem is that when you come to cardiac surgery, and most cardiac surgeries are direct vision, so camera is not there. So if you give a camera to a resident who has been well trained during his residency in laparoscopy, so his skill was always there. but that skill degrades over a period of time and he is doing cardiac surgery training. So if we can able to give them, so they'll be very good in handling the camera. We have a 0 degree and a 30 degree camera with us. So that part must be given to residents. They are very good at it. Then port placement. So port placement, you can start having a protocolized system of post placement, and then you can give your residents an opportunity to do port placement, and they'll do a very good job, I am very sure. Then coming to docking of the robot. If your team is very good and the residents become a part of a team, they do it day in and day out, and they are able to dock the robot very easily. Then coming to instrument exchange can be done by a PA, but residents, if you teach them, it is not a difficult job to teach them, and once they are proficient, they are able to do it. Then understanding robotic cardiac procedures step by step is very important. What is very good about bigger training centers in US, Korea, that every step, every surgery can be broken down into steps. And that's what we are trying to do in our center, that each and every surgery is broken down into smaller and smaller steps. So a step-by-step understanding of robotic cardiac surgery procedure will go in a long way in teaching our residents. And then observing handling of complications. This is, I have written at the 8 point, but I think it's one of the most important things. A resident is as good as what he has seen happening bad. Complications, we cardiac surgeons don't share enough complications. On big platforms like this, we should be sharing more complications and how do we manage complications rather than showing everything which is perfect. Because we all know as cardiac surgeons, surgeries is not always perfect. So we have to be honest on these podiums and say, yes, a complication has happened. This is how we manage the complication. And we may have sessions on managing complications and robotic surgery in most conferences. And then hands-on practice on the simulator. I think simulator, and then what you can do very simply is whatever is Dr. Balki was talking about it, that you can have a leftover ITA and a vein, and you can teach a resident, put it in the robotic port thing, and they can dock the robot and they can practice training. It is very important for young surgeons and people who want to learn robotic surgery, people who want to learn TCAB, to have that facility. And it is not very difficult to create. You have to be a little bit smart, and you can create those. We all have residual veins in our theaters. We all have some segments of IMA in our theater. We can use them to create models where we can train, teach, and become more proficient. Thank you so much.
Very good, Anubhav. That was a good talk. And I've been in this racket of training surgeons for the last half a dozen in this country. Our problem is we got some of the best, but the quality control that should happen in a country like ours is not there. So you can have a very good training, you can have a poor training, and when I go as examiner, there's so much difference. So I passed them. I said, but you come and work with me or some good center and learn. By failing you, I'm not achieving anything. So you have to, because they are limited by the exposure that they get. So unless all the residents and younger surgeons get good exposure and then good surgery, then only they can learn. And there are programs where they do only 100 open hearts a year or something like that, and still they're recognized for MCH. So these are the problems that we face in our country, and I'm in the process of making some videos on basic procedures, aortic valve, mitral valve, whatever else, basic training of this surgical residents. But I will ask my friend Sudhir to encourage training program for young surgeons in the robotic practice. But before they do that, they should be well trained in the surgical procedure themselves. Then that robotic should be the next step and not the other way around. So thank you very much. If you have any questions for Anubhav, please come forward.
I think I may add some comments. I think it was a great analysis and I think outlining methodology in terms of how do we get people step by step. I think one thing, and being in the government hospital setup, and we are also pursuing through some back channels to really introduce the program into as a curriculum as part of the training. And we start out in the 4th year medical college. And people who do undertake postgraduate surgical, different specialty, it doesn't matter which one, then continue with that exposure in terms of hands-on. And what we lack actually, unfortunately, we have got in India particularly when we are talking, and that may apply globally also in many other countries, is that the number of robotic systems are small. So even though they are in medical colleges, the professors or attendings are in their own learning curve. And especially when you get into the corners whereby things can happen, then hardly anybody gets an exposure to actually do. So I think if we start out as a curriculum whereby they're taught literally during the 4th year about, so one is that they will get to understand, how this whole robotic system works. It's very important, and I keep emphasizing that, to understand the engineering side, because it will make life easy for people to use the system. Also, how it functions, so a lot of time people have preconceived ideas, or I cannot feel, or I'm opening my, fingers, and I want to be able to, and they think that actually they are opening when it has nothing to do with that. So if they understand the science of it, that these are the encoded values that are getting transmitted through a optical sensor or whatever sensor, electromagnetic sensor, and that value goes to the drive and the motor, and that's how exactly things are happening. So certainly we will understand our troubleshooting part. And secondly, then, teach them some very basic skill set right from the beginning. Because ultimately it is a hand, eye, and foot coordination. And so if they learn the mechanics actually of how the robotic system works, how it should be used, and that means very step-by-step approach. Various defined exercises, pick and place or move here, move there, the whole skill development without getting onto a clinical setting. And then they should become observers. They should become tableside assistants during that phase, because there's nothing better than being in the operating room and seeing. And then gradually we get them into actually doing things during their residency. But again, it comes down to you must have people who know what to do on the professor side or the teacher side. But again, I think with the technology, a lot can be achieved over a period of time. Same thing with the table size. So you've got nurses. So all these, places they have nursing colleges. They will have physical therapy. So basically, all support services are part of a system. So we need to start training them also. One of the biggest, having launched various programs over the years, I used to spend time literally investing into teaching and teaching them that you must run it as a program. And we created really a very defined process whereby from admission, whereby they are taught it is a different surgery, the patient and the family. And discharge planning begins at the time of admission, that you don't need to stay in the hospital, paint a picture that hospital is not the best place to stay, potential infections or anything else, and cost, of course. But then also show them videos. So create like an education atmosphere for their families, and they will become the biggest mouthpieces to spread the message. Because we cannot advertise and do all kinds of things based on the guidelines of marketing. So I think if we start, and that's what we exactly used to do. When the family will come, I'll bring them into my conference room. I had a large screen TV, and I will show them, of course, you ask them that you guys can see, surgery, or just fundamentals actually of that thing. So once they become comfortable, and a lot of these misconceptions about robotic surgery is gone then. But they really understand that my surgeon is doing the surgery, and it is nothing but a tool in the hands for them to be able to do these complex operations through tiny holes, and these are all the benefits. So they will, I remember when I launched the program here in India, and because there are package pricing that occurs in a lot of these private hospitals, and they don't want to go home. Because they have paid the money. So I tell you, they're ready for discharge. Oh, I didn't have a bowel movement last night. Can I stay one more day? I felt warm. Come on now. We know exactly what is happening because, yes, there are certain situations that patients, based on their own setting, home setting, or if they're in village or concerned about coming back for anything or hygiene at home. So there are these considerations, I think, that at least in India one must take into mind. But again, this can be determined at the time when they meet the social worker. Understand, so if you really run it as a program, understand their own needs and customize that. Because see, ultimately the benefits of robotic surgery we know, beyond the operating room, is train the physical therapist, the respiratory therapist, the nurses. They are different patients. The recovery is different. ICU nurses, get them going. Some patients that we discharge next day, we have to literally pound. But then once people got convinced, and then when they see patients going and doing really well, it is absolutely implementable. But again, we must run this thing as a program, and this is what also needs to be taught during this and, at the hospital level with the staff and so on. And then, of course, the whole skill part will come in time. And then, of course, depending on the specialty, a lot of case observations that they must do. There are all kinds of videos that are posted today in the teaching side. So I think it needs to be run as a holistic, and I think the best thing would be for us to talk to, let's say, especially in India, Medical Council, National Medical Council. We have been trying for the last whole year, and nobody, seems to bother. That's the, unfortunately, that's the frustration. We met with DGHS and met with the health minister. So I think, maybe with the government institution, you guys have a better say. Or if AIMS, for instance, and Safdarjung gets behind, and you start these programs, we'll be more than happy to actually help with the curriculum. And then literally there is global experts available today. And using online, we can literally get them exposed to all of these, rather than meeting in a conference setting like this. So if we really create, and my goal is through our ICRS that we are creating, get the global leaders to help create these modules. And suddenly now when people also listen to people who have a lot of experience, it is different. It changes things. So I think, it will take time, but just think about it that in next 3 to 4 or 5 years, what pool of people we will create instead of people learning in the middle of their careers. And especially in private practice, you talk to them, oh, I've got to do 4 cases in a day because that's how they're paid. So they don't have time to spend in learning curve. And so that, get discouraged. So I think we need to look, what is present. We must address that regardless. But how can we create, because this will be the future. Sam, thoughts on you?
Sudhir, there are a few things, particularly in India. In my practice in the last 50 years, number one, patients have to travel long distances to come to the referral centers. In fact, from all over India, they used to come for things. So they are a little different. And the living conditions, particularly in a city like Bombay, patients have hardly any place to live. I can't discharge them unless you're 100% sure everything's okay. So there are certain situations in India which are peculiar to India. One is transportation, one is living standards, one is help available round the clock or whatever that is. So we have to just modify this according to the local situations.
So can I make a comment or? Yeah, over here.
My name is Dr. Adarsh Kopula. I am working in Max Hospital at Saket. Anubhav, compliments in any conferences like that, people spend very little time in training methodology or pathways. So I appreciate your taking us through the pathway of training. I would like to make a comment here. In Max Hospital, I have started a competency-based surgical skill training for DNB 6 years DNB training residents. And the philosophy of that is, one, that we have to standardize skill training, like Dr. Devendra Saxena said.
Available, virtual training, modules, online, webinars, direct tele-proctoring, telesurgery, so all that exists today. So people don't really have to come to Bombay. And I know how difficult it is, one of the most expensive places, and you can't really, most people coming from villages can't afford the hotels and on and on. And this is really why we are working to try to use telepresence as much as possible, not only for diagnosis and delivery of care, etc., but also education. We've got all kinds of ideas, and I know the forum will not permit to get into all the details that we have plans. Literally holding camps, for instance. You send our mobile vans, okay, hold these screening camps. With that, attach education for, let's say, these rural communities. Because see, the biggest issue is ignorance, or not actually knowing what can be done or should be done. So I think we need to really combine, and these are, I must say, massive projects. And we will need the help of medical colleges and the government. But see, our problem is we don't look at in the bigger way. We are all kind of discussing things at a piecemeal, small level. Until you really think, take India as a massive population, 65% living in, how do we actually educate people? And same thing will come down to the medical colleges. And the thing is that now the whole thing has become so expensive also. So when the people come out, they want to really see how are they going to pay off their loans. And then practices that are sometimes not so ethical, they get into it, okay? And that is the worst part, that suddenly the focus on patient and science is gone. And the oath that we undertake is on locked up somewhere else. So I think we really need to approach it differently, and sometimes, we get used to the old system. And until we think completely outside the box, we will not create a larger level change. It will always get limited to a smaller number. And so we need to think really, honestly, at a very different level. And that's where the government should get involved. And unfortunately, we don't get opportunity, no matter how many ideas we have. You go up and meet the minister, firstly you have to go through 4 or 5 people, and everybody wants you to pay them, and which we don't. And that's why we rarely get to meet. And secondly, you go there, they will have 10 other people there in the room, okay? You give them a bouquet of flower or put a shawl, then they have their own photographer, and they'll take some pictures for 5 minutes, and then you tell, send us a letter, what you would like us to do. We do, and that's the end of it. And that's a recurrent theme that I have personally gone through over. Because see, when you want to think differently, you need help at a different level. But unfortunately, we are governed by politicians, and I'm not going to get into the negative aspects of, dealing with them, but unfortunately, we have to deal with them. So we have to figure out a practical forum that we can actually succeed making a change. Sam, you have?
Yeah, I was just going to add, this is a topic we could spend hours, the rest of the session talking about education and training in not only surgery, not only robotic surgery, but all of surgery. I think robotic training adds a lot. I want to congratulate you on a great talk and bringing together a lot of different, previously published but almost somewhat becoming outdated even as we go along, because we came up with those numbers, 250 in the institution and 75, that's very local, and the numbers would differ based on the country and based on the locale. I think what Sudhir said about teleproctoring and some of these new concepts in robotics, robotics is the only scenario where a teacher can train a student and not lose their sense of how they see the case. When you train somebody on an open, and Dr. Saxena can probably tell us, when you go to the left side of the table to help a resident do a case, you're disoriented. It's not in the same perspective that you see the case yourself. Whereas in robotics, with the second console, you're seeing exactly what they're seeing, and you're seeing what you normally see every day, and so you're not, you're not out of your element in terms of how you conduct the case. And so I think the training capabilities are much more enhanced, but the nuances of all the list of how many you need before you do this and all that, I think, is a moving target, and how you reach it is also a moving target based on where you are. The capabilities of robotic training, I think, need to be divined purely for robotics and not for anything else. And I think we need to take it now with surgeons who are already established in their own practice and how to teach them robotics, but much more importantly as to how to bring up the trainees who are evolving in different specialties doing robotics, and they're going to go through their cardiac training. I think one of our models should be what the other specialties have done. What has urology done? Now a urologist who finishes their training program and does not know how to do robotic prostatectomy, they will not have a practice in the United States. I assume it's probably similar in India. Mm-hmm. And what is it that those guys did in their residency programs that enabled them to come out fully trained like this? And I think that's a goal to aspire to. It's going to be a long time before we get to that goal, but that potentially is what we need to be doing.
I think at least in Mantra you don't need a dual console to see. That's why we designed that everybody absolutely has the same 3D view.
Right.
And you can either sit next to the surgeon, you can have 2 people, 1 on each side, or 4 people, 2 on each side, and they will be able to see wearing glasses.
Quadruple console.
That's right.
Dual console.
With 1 monitor.
Yeah, right.
And then they will see what surgeon is doing also, sitting next to the surgeon, because when they are in another console, they don't really know what the surgeon actually, hand motion, foot, etc. So in our system, this is why a lot of thought process had gone into designing this thing, whereby not only they are watching the same 3D view, but they are watching what the surgeon is doing, how they are moving their hands, what are the position for certain suture angles, etc., etc. Then you have got observers who can be in the room. There is a 3D monitor for them. So I think, so those things actually make life easy. And yes, sir, I think you were trying to say something. I think press your microphone.
I think the distinct advantage of robotic surgery is, like when I teach any competency, I have to use my camera to video record the guy so that I can play it back to him to show where he has made the mistakes. But in robotic system, everything is digital, so you can use the digital recordings to teach them competency-based wise where all the mistakes are occurring, using even AI to find out where all the mistakes have done. It can also be used to train an AI agentic kind of form that you're developing to find out how to train trainees about the skills of surgery for that particular competency. So the distinct advantage of having simulators for robotic system to be applicable for training needs also.
I'm not going to get into the debate. I won't get into the debate of simulators that many other companies do. I think we are, first of all, developing all kinds of things which are AI-based and software-based to be able to actually help. We record every single case, and people have ability to download. I think the best thing really for people also is watch their own videos. We used to do that as a team when in the early days, and that's the only way to improve. because you know, and then if it took longer time, why? And so on. So I think, and we are working on all kinds of AI tools right now that will pick up issues. But please understand, these things do take time to create algorithms, and then the messaging. So sometimes surgeons are also a little bit different, that they don't want to be told. And if you have a voice message, they'll say, just shut up, let me operate. So we have to be kind of find a balance. Can we do one thing? I think we can go to the operating room. I think, you know what Ritvik went through, it's absolutely admirable, and this is something that we were discussing in the panel discussion regarding, unforeseen things. And right there is a burning example of dense pleural adhesions and how he gradually freed up. Ritvik, can we talk to you? Can we get the communication, please, in the operating room? He persisted, and now see, same operation. Can we get audio from operating room? Ritvik, can you hear us?
Yes, sir.
Yeah. Firstly, I want to really appreciate your tenacity and persistence to deal with a difficult situation that many times we all face. You very patiently and persistently freed up the lung. So can you tell us as to what were your initial maneuvers when you got the camera in, and what did you do just for others to learn? And it's great what you're doing, and I'm seeing you there. So maybe if you can talk about initial part of the...
Sure.
Yeah.
So I must first of all appreciate my team. So initially the first jerk is that let's not do it. But I think it's very difficult additions from top to bottom on the left side of the lung. And so initially what I thought that I'll just put one port on the right side, this thing spatula, because me and Nitin had a discussion day before yesterday. He had the same case. He did the same thing. Then he just put the camera and the right port, and with the right port he dissected all the adhesions and then cleared the adhesion and went on. But in this case, we were trying to do that for some time, but at the end we failed to do that because opting. So we did that for that, sir.
And then you.
It was not described, but it is probably a desperate move today to do this.
Yeah, no, this is a die-hard robotic surgeon, no question about it. So it's good for you.
Thank you, sir.
I may comment. We presented a paper back in 2011 at STS in San Diego and reported 164 consecutive cases without intraoperative conversion. And so we looked at actually all kinds of things as to what led to conversion, even though they used to be smaller, but we wanted to see, are there things that we can do so we can avoid conversion? And one of the things was, of course, a lot of these type of situations, but also pulmonary intolerance of single lung. So what we started to do, literally, we will tell them to put PEEP on their right lung. Secondly, initially, you already produced a pneumothorax. So we'll tell them to take both lungs. So with the CO2 pressure leeway to deal with the gaseous exchange, and the PA pressures will come down and so on. So I must say, when we looked at what were some of the reasons for conversion, a pulmonary reason was one of the things. And then we really just sat down and talked to the anesthesiologist. What do we need to do? And then we came up with this protocol. And they used to attach, I think, some PEEP type of, this thing on the right lung. And so they could do that, and left lung remained partially collapsed, but we were able to do without having to convert because of that. And I know, Sam, you do also let the lung come up, and, especially when taking the IMA down, it doesn't bother. And even the other IMA is okay because it doesn't come in the way, because we are way anterior and above it. And CO2 will give you space. And yeah, definitely when you go to posterior vessels, then you have to, again, get that out of the way. Any comments, Sam, on how you're dealing with the lungs issues?
Yeah, we've published on this, and enough domain where maybe it's not as high as it otherwise was, and you can find a channel to keep open for your instruments and whatnot. So we've moved to what I call double lung ventilation in all of the TCABs with some CO2.
See, while we're on the lung issue, you know that unilateral pulmonary edema, and especially in intracardiac cases or mitral, that's well described. And one of these, I think we had a discussion way back with Doug about this thing, and I was telling that there has to be a very different element in pump cases versus, because in all of our coronaries, we never see it.
I know that because I read it in a book. I know that because I did it several times. And it's a one-to-one relationship between the extent of your lung dissection versus the likelihood of developing unilateral pulmonary edema on a pump case. However, on a TCAB, I would do this every day because when you're not going on the heart-lung machine, I think this lung, it'll be white a little bit, later on today. You probably won't extubate it on the table, but I think eventually it'll improve. And Bob Key, I wrote a paper on UPE back up when he was in London, Ontario, and he quoted an incidence of 25%.
Boy.
But this is on a pure radiologic diagnosis.
Right.
This is not like the flagrant one. I mean, everybody, when they have a little bit of edema in the lung, you'll see it on the x-ray, it gets better, it's not a big deal. And that's how they defined it, x-ray unilateral edema. But the clinical kind that we dread is something obviously you want to avoid.
Sudhir, I have a question for you.
Maybe you turn the microphone on, please. Yeah, just press the button. Right.
The question is, we all know that interrupted anastomosis is the best anastomosis for any vascular procedure. Now, if we can use the thing that you have shown in your diagram.
Can I have a clip, please? Clip.
We have been using continuous primarily for
Dr. Neeraj, you can ask any anesthetic question if you want. Dr. Balki is there. If you want to ask some question, you can ask.
Somebody wants to say again?
I think Dr. Devendra here was raising a question, not to you, Ritvik.
Yeah, okay.
Yeah, go ahead.
So the question is, why don't we all use those interrupted clips for anastomosis of all vascular procedures and popularize that instead of using running sutures and proline and all that for vascular anastomosis?
When you say clips, what do you...
Whatever I showed in the diagram that I was seeing just now.
Oh yeah, so that's firstly, it is in development. Secondly, if time does permit, I will show you a little video of my U-clip technique that we had developed. And so yes,
clip नहीं है आप क्या कर रहे हो?
need some technology or suture that you can do interrupted anastomosis. I think we all know Cleveland Clinic, in fact, they used to use 7/0 silk to do interrupted anastomosis and tie every single time. But, definitely, unfortunately, U-clips went away. Cardica, that stapler, also was an interrupted anastomosis. That went away. So we are really working towards...
There is no clip again here.
It's all work in progress as we speak, and hopefully in the next 2 months we will be running clinical trials, yes. And not just that, just think about it, people who even use vein grafts, for instance, and not everybody is doing. When you have a vein sitting and you can have your tableside team or PA put these U-clips or whatever what we're going to develop right there on the table. It's ready to go, and all you have to do is just drive them. So there are things that will have tremendous advantage of what we are working on, gradually.
That'd be a great thing.
Yeah. Yes, Anu.
I think that hand-sewn TCAB is still a difficult operation. It may not be difficult for Dr. Balki and for Dr. Sudhir, but for a surgeon, I think a suture hand-sewn TCAP is still top of the line or difficult operation to do. The operation will become very popular when it is much simpler to do. It is much more reproducible, and everybody is able to do it.
So I think.
Can I have the camera clean, please?
What will really occur? Biggest challenge in every meeting that we have discussed. Why TCAP did not take off, and this is why Intuitive stopped supporting it, and no other company seems to be gathering into it because of Intuitive failure early on. Yes, absolutely, it is a difficult operation. Some of us die hard, but actually, please understand, we did things very systematically. That is one of the problems that surgeons don't want to put in time to do that. Look, every Sunday I used to go and bring my team. We'll practice. We'll do the pig heart anastomosis, make videos. So, see, until you really invest time, and I keep reminding people, and I don't want to sound like broken record, but that's how it is now. Because I've said this too many times.
Can I have the camera cleaned again?
How much time we spend becoming a general surgeon? How much time we spend becoming a cardiac surgeon? How much time beyond that we spend to become good cardiac surgeons? On average, for most people, it is 7 to 15 years. Okay? And if you're lucky, during residency, you actually get to do a lot of work. Those are not very common situations in many parts of the world today, especially when you talk about the robotics. People don't even know themselves. What are they going to do? So this is why I think if you just look at, if you have to spend, let us say, 2 months, and every day you do 1 hour of practice or whatever, and I don't personally like, this whole simulation thing. Is, in my opinion, you just sit down on the system itself, because that's what you will use later on, and bring whatever tissue, because ultimately we have to operate on a patient, not on the computer. And yeah, someday we'll operate on the computer ahead of time, but that's different. But so just practice and go through the exercise that I need to learn and commit to it. Don't dabble into it and just because you've seen somebody else, I'm going to try out. The trying out does not work, and that's why it fails. So I think, see, it is doable. Now how come, let's say, 10 people in the world today are trying to do or are doing TCAP, but they are doing it, isn't it? I think we need to develop the attitude, if you can do it, I will, or I can, and if you don't, definitely I will. I think if you develop that thing, because see, cardiac surgeons are highly skilled, isn't it? It's one of the not an easy specialty, and it's a highly sought out specialty. So I think we just need to also equally commit, because this is such a wonderful thing for the patients, and we are evolving ourselves also as surgeons, and this will be the future. So the question then comes down to how quickly we are ready to get on this bandwagon. So I think, yes, I agree with you. And sometimes you really wish you were not there that day in the operating room. It happens.
Mitral uptake has been the maximum in the US. I think 20% of the mitral valve repairs in the US now are done robotically. So why it is 20% for mitral and it is less than 1% for TCAP? The answer is very simple. For mitral, there's a lot of space. It is easier to do. It is more reproducible. Anything which is the learning curve is not very. So how many of us will climb a Mount Everest? None of us. How many of us would want to climb a Mount? So we have to make things simpler. Whatever we do with technology, we have to make things simpler. Why urology has got such a massive uptake of every center in US, in India, most centers in India. If anybody is doing robotic cardiac surgery, it will definitely be a urologist. It is how a specialty takes up a project. So our mitral valve colleagues took up that project, and they somehow were able to convince that for mitral, robot is very good. For TCAP, I think people, stalwarts like Dr. Balki are sitting, But why we have only 10 surgeons in US doing an active TCAP today?
I think
because, you know, Sam has stolen all the stabilizers.
Yeah, right. Stolen all the limelight? No, he talked about stabilizers. I think one of the reasons, and you have a very good point, and I think it's very valid, we don't know the uptake of TCAB and how it will evolve. I believe that with a new generation of robotically inclined surgeons that are training now in heart surgery, we will have more utilization. I keep calling, and Sudhir has said this before as well, TCAB is the highest form of coronary surgery, beating heart TCAB, not arrested heart. And it is a high form, there's no question about it. It will take a lot of training, but I think the training that it takes to bring a surgeon from becoming a fully fledged heart surgeon to a TCAB surgeon is shorter than it should take from taking a person out of college to become a heart surgeon, which takes about, I don't know how long. In each country it's different, but somebody who goes to medical school doesn't know anything about surgery, and all of a sudden after 6 years of a I6 program in the United States, or you know, whatever, 4+3 or 5+2, which is what we did, all of a sudden they become a heart surgeon who knows how to stop the heart, restart it, sew on a coronary, do all this stuff. And if you're in India, you finish that program and you know how to do OpCab, you know. I think that is a much higher bar than taking that OpCab surgeon and turning them into a TCAB surgeon. Because all they need to do is become facile with the endoscopic environment and understand the situational awareness that is required to be able to maneuver inside the chest. That's all that's required. You know how to sew, you know how to put a shunt in, you know how to talk to the anesthesiologist to maintain the hemodynamics, you know lung physiology, you know all of these things. The only thing that you are lacking in that environment is the ability to train your eye on a close object. In 2.5 and 3.5 mag, I see the object like this. In TCAB, I see it like this. That's the only difference. And so once you get past that, I think people will, and obviously there's training and there's, you know, lots of time involved, but mitral, the reason mitral, I think, took a spike, a significant one, and it's not done yet. I think mitral is still growing, is because the visualization is superior. There's no question about it. Yeah, and so I think most people are starting to realize that, and I think TCAB will follow. It's just a matter of time because it's more complex. And coronary surgery through a sternotomy is harder than any other surgery. I mean, I've heard surgeons all the time say that. Our most complex arch guy at our place, he says, don't give me any coronaries. I don't want to touch the coronary. And he does all these massively complex arch reconstructions and aortic, you know, procedures. So I think you bring a very, very valid point, and it's upon us to make it into a realization that TCAB will grow. We don't know that that's the case. I have a strong belief that it will be, but it's not the case yet, so we can't say much.
And I think we have repeatedly said, on a beating heart, with a suture, especially running suture, it is a real challenge, okay? Even in our hands, when we have done, you know, of course, I used either the Cardica or U-clips in those days. And it's only when U-clips went away and Dr. Gao's soul rest in peace, he bought all the U-clips and they went to China. And so I used to go and operate there, so we had U-clips. But essentially, Medtronic shut it down. Okay, wonderful technology. So I think what will revive TCAB, one is an automated connector. Because if you can load the IMA on a device and you put it in and you fire and you're done. Reproducible, and all you have to do is place a little purse string for the anvil hole. We used to use 8 Gore-Tex, and then we used to leave a couple knots, you know, hanging there. And as soon as you take the anvil out, you tighten and you're done, literally. And it's reproducible anastomosis because just like staplers in other fields, mechanical firing, every single time, it will do the same job. So I think that definitely will revive, and also developing these interrupted techniques, shorter suture, because there will be times you have to do side-to-side anastomosis. And then, of course, you cannot use Cardica style device to do that. So you still need to be able to sew. So I think, we are working on that. Somebody talked to me about, reviving U-clips, but it's a very complex development. I was involved with them early on. And the shorter sutures, we helped, all kinds of things we did with them. Their plant was in Mexico. And actually, if you take the U-clip, it looks like it's a coil. And it is so thin. It's like, probably thinner than a hair. When you try to take out and, it extends. So what we are working right now is this suture. See, suturing is easier, and I think, so that becomes very easy, because in running suture, you are leaving loops. It's loose. Now you have to pull, and hope it doesn't break. Now the newer sutures, they don't break. But also I think the other thing that we got talked about the other day is lock every third suture or something. Because the sutures are loose and then you go and try to repair, just like what happened with Lalit.
You know who recommended and started using that locking every third suture? A young gal by the name of Kelsey Gray, who is now doing arrested heart TCAB, because she trained how to do arrested heart cabbage, but she's now really leading the field of all the juniors that we've talked to and trained, and she's been to my OR multiple times. She's doing routine. She's now at Yale. She used to be in Cleveland with one of her mentors that moved there. And so it's you've never heard her name, but she's
I did not.
She's doing TCAB, a young gal, barely out of training, maybe 3 or 4 years, and very comfortable in the arrested heart and doing obtuse marginals and posterior wall and things of that nature, and really making a name for herself. And I think that's the generation that's going to change, at least in the United States. They're more comfortable with arrested, no question about it, which is fine. She knows how to use the endo balloon, and she has access to it. It's a completely different operation, and it's made me almost start to believe that there is a role for arrested heart, maybe in the beginning of somebody's evolution into TCAB. But that's, and that could be one of the reasons why mitral has progressed, is because you actually do arrested heart mitrals. You don't do beating heart mitrals.
You're dealing with bigger structures than tiny coronaries. And I think, this, what was I going to say? Take Lalita as an example. In India, what's the difference between him and other surgeons? Very enthusiastic to try newer things, okay? I remember, I think it was almost 2 years ago when I gave a talk in Jaipur. He came, I had invited some people for dinner. Dr. Bana and Lalit showed up. And Lalit was really interested. Of course, they have to go through the bureaucracy of acquiring a robot. Once he acquired, you look at how far he has come. Or you look at this Patna doctor who did not tell us he has done 135 cases. Now, they have done it. Now, I don't know about the TCAB, probably not, but look, Lalit has done it, because he just kind of put in his efforts. So I think this is really what will take for surgeons. It's doable. I think question is, are we willing to do it?
I always give that analogy. If you look at an Air Force, the most complex fighter jet have been flown by 22-year to 25-year pilots. There, one plane would be costing more than the whole hospital which we run. And it is fighter pilot would be flown by a guy who's barely 20 years old. So it is the thinking which we have. If you say that, no, you have to become a cardiac surgeon first at 30 years, then spend 10 years becoming a coronary surgeon, and then become 10 years to become experienced and to get a hands on your robot, then I think we are losing the battle there. I think the way forward is to get exposure to people who are very young, train them accordingly. They need not be trained in everything else. They must be trained on a robotic TCAB, and if you give them that direction that yes, you are the guy who's going to take it up. When we started doing a renaissance in this country in 2020, we had hardly, everybody got trained. Dr. Yugal got retrained with us. Dr. Yusuf was the only one who was doing. Dr. Satyaki started at the same time. And we had a meeting somewhere and people said, oh, no, we don't have any mentors in the country. Sir, you were not at that time available as a clinical mentor, but we didn't have any mentors in this country. If I have to do a robotic mitral valve, whom do I look up to? So what I did was, I went to the internet and I saw videos of Dr. Balki, Dr. Sloan Guy. I looked at all the videos which are available on the internet, and everybody have a different story to tell. If you look at Dr. Sloan Guy, he'll say that I always put a diaphragmatic stitch when I'm doing a mitral valve. He will, in his videos, he'll say, I will not do, and he said, I will do only when I have an access to a endo balloon. So in one of his talks, he said that if you ask me to choose between an endo balloon and a robot, I'll choose an endo balloon. So it's how it is. So if we have a good teaching material, stalwarts like you, sir, has got lots of teaching videos. They have trained so many people. They always give those analogies. Dr. Balki, one of the Dr. Balki's statement is, you, if I'm not wrong, sir, in quoting you, that you kill the vein before it kills you.
Kill the vein before you kill the artery. Yeah.
Yeah, but I think I'm very impressed. I mean, you say that there were not mentors in India. I think that SSi Mantra has revolutionized the Indian robotic scene. I mean, I was very impressed with all the presentations that I've seen in the last couple of days of surgeons in various parts of the country. You know, that the gentleman from Hyderabad today was very impressive. I don't know if he's here. He's named.
Badami, yes.
Yeah, and just young surgeons who have been kind of growing very quickly in robotics. I mean, even Ritik, I don't know how many cases you've done, but to do that dissection.
108.
108. And you're doing your 109th case and you have all of these adhesions. Most people would say, get me the saw or get me the mixed cabbage setup. But you persisted with robotics, and I think that's a testament to the volume that you have here in India. And I think that this is going to be a very quick curve where you're going to be leading the pack in robotics on the global scene. And I would not be surprised that this TCAB adoption is going to happen. Actually, I am predicting it. It will happen in India before it happens anywhere else.
That's right. I think it will, because one, we have an affordable robot, we have a stabilizer, and we are working literally very on a warp speed to create these technologies that will make it easy. Because you see, enabling technology, you see what Intuitive did, they gave us the tools, and we had to figure out what to do with them. Didn't think as surgeon, what a surgeon needs, what do we need to do, and this is where I think we differentiate ourselves on having been in the field. What will make life easy, where more and more people will do. Absolutely. One thing, Anubhav, you talk about younger surgeons. You know, I was leaving Odessa, Texas to join University of Chicago in 2007, and the reporter came to me and asked, you know, it's like a video game. The younger generation, of course, you know, they're used to doing things while looking at the screen, but is it easy to teach older people? So I told him this. He asked me the question, can you teach an old dog new trick? I said, this old dog learned. I was 55 when I got onto this platform. So it's a mindset. Yeah, it's a mindset and being patient-centric. I think those two things.
Yeah. Great conversation, though. Good discussion.
Anybody can learn. If anything, it will extend. So you won't want to talk.
Yeah.
In what I do in these cases, when there is bleeding, deal with it right away, because it will spill blood, it will cover a bunch of things, and then makes it difficult later to find where it is the source.
Yep. Yeah. Bleeding begets bleeding.
Yeah. And it's venous bleed actually, so it's not. And that's why a lot of times we tell people, you know, I've seen surgeons do a lot of blunt dissecting. Really tell them they use cautery, short push, and use cautery as much as possible. You know, little pulling or pushing is okay, but to constantly do blunt, because you will tear the branches. Yeah, especially when you're not seeing or when you're doing as a pedicle or with the vein and all that thing. With skeletonized, of course, you see everything there as you go.
The other thing Dr. Balki usually teach, which I have learned on the that you should not pat the IMA like a pet dog.
You should not what?
You should not pet the IMA like a pet dog. So you should not be doing that.
Oh, yeah.
This movement too much.
You know, we have no idea how much pressure we are applying, and it can produce a hematoma inside or later dissection.
The best way to harvest IMA robotically is to go skeletonized. Leave both the veins at the top, bring the IMA down, and you have very little branches to take care of, and you are in a very good state. And robot actually allows you to do that.
Yeah. The endo wrist, the magnification, you can literally see behind.
Yeah.
Now, if the vein is literally overriding, and sometimes you see these bridges going over the IMA, at that point just take it with the vein. But I think one thing is really the best way is firstly lay open the artery, take the fascia completely all the way. Because I see a lot of people that, you know, will take the fascia a little bit and start dissecting there. And it just takes extra time, and it won't take long once you get used to it. Just take the entire fascia and then start proximally. I mean, that's at least what we develop, whereby there is a separation between vein and artery. And especially if you're going to try to skeletonize, that's the best way to go about the phrenic nerve area, because that's where the separation is occurring. And once you get into the plane, and try to stay in the plane. I think he's going to do single. I think the time is spent, and I know. In fact, I was going to tell him, now since you have cleaned up everything, just go and take Rima first. I think the time factor is trying to. I think that needs a clip. It's arterial. Are we connected there? Ritvik, can you hear us?
Clip the neck.
There you go, you read my mind.
Give me clip, please. One more clip.
I think, Ritvik, I don't know if you can hear us. It is far away from your IMA. Just use your cautery and burn it, because you're not really seeing where it's coming from. Just use the cautery. You'll be safe. Oh.
Oh, my God. Careful, careful, careful.
Just poke the. I tell you, this used to be a big challenge in the early days of with the 2D vision for the tableside team. You know, they'll bring the clip and poke into the thing because they cannot tell how deep. Anubhav, what are your cautery settings when you are doing the IMA?
So it's 30, that cautery is 30, so in intuitive it is 3. So usually 3 cutting and 3 coagulation.
Dr. Balki said he should leave at 4:30.
Yeah, he should. Right.
So I can call Kuldeep too.
No, the Kuldeep is not here. So, because
Can I have the clip, please? Oh. Thank you, guys. I have a question to Dr. Bhalki. Is this?
I think Sam is in the bathroom and he didn't take the microphone with him. So Ritvik.
Yeah. So in this case, sometimes we get blurred by this blood, and although the bleeding is controlled, but still sometimes we don't see anything. So there is any futuristic idea of getting some papaverine sprinkle in between?
Not really. I think the best thing, if it is bleeding and you are away from IMA, what we would do immediately cauterize that. And now we are using the bipolar also in the left hand. So you can use the bipolar in the left hand and just cauterize that. And secondly, the problem is that if it is avulsed from the IMA, and I've seen that happen, with some other surgeons also. It happened with me when I was in Australia, and this larger second intercostal branch, and the surgeon was doing it, and it was there. Now, obviously you cannot do anything at that point. You cannot use cautery. There's no stump to put a clip. And so what I did, I just gave 5,000 units of heparin, brought in 2 bulldogs, put one on each side, brought in ATO, and repaired it. And it works out fine. Also, even sometimes if the dissection has occurred for whatever reason, again the same principle, bring the bulldog, cut them end to end and re-suture it. And it can be used because generally it is localized pretty much. I think the only way to deal with bleeding is just deal with it right away, because it creates actually, the thing is when it becomes old blood and behind it now you cannot really see anymore. I think one should also distinguish between venous and arterial. So, and just deal with that as much as possible right away.
Dr. Ritvik, Anubhav this side. So I think you're using a diamond tip on the other side.
Yeah, you're using a black diamond, but...
Yeah, so I think you can use a micro bipolar, that would be better.
That's right, micro bipolar is very helpful. In fact, I've taken Sam to show our instruments. So we now have 5mm instruments, Ritvik, and I think you guys may actually consider that, because the micro bipolar in the 5mm is even smaller than the adult one. And those will be, and even see for taking IMA, you can use 5mm instruments, and that will make it much easier. You don't need a big horsepower. And so you can try, actually, our team can send you 5mm instrument, and they attach to the same, we have different cannulas for it, but attaches to the same system. And the other thing that I do, when you know where these branches will come, especially the larger ones, so I basically go proximal to distal and keep separating, and so that you are not doing anything blindly, and you will see the branches come, and then just clip them at that point. And this looks like semi-skeletonized anyway. So I think you can create a plane on the other side and where you can get behind it fully, and then just stay in the same plane, and then you'll see the branches come. So you're not kind of going blindly just like this. Yeah.
It seems like it's the IMA is almost attached to the periosteum. You know, these are hard.
Yeah.
And you just have to take your time
and you just have to peel off. See, the thing is, these type of things, because if you, let's say, have separated and created a plane on the other side, medial side, so now you can retract it gently, and just short burst of cautery and little blunt dissection, you can peel it off. I mean, we have seen that, especially in certain cartilage areas, it is stuck. And you just have to be patient and just peel off gently.
Really, we can go to the next paper then. Dr. Sadiq, is he here?
I think two of our speakers are missing. And me, rather than talking about, I have this thing about globalization, I think we can more like do it as a panel thing. I think a lot of those topics actually have been covered, and no reason to talk statistics and numbers and all of that thing. I think people know. The question that we need to address is how do we globalize this whole thing? And of course, we have, maybe we can spend a little bit more time, yeah.
Dr. Adil is here.
Adil is here?
Yes.
Where? Yeah, so Dr. Adil, do you want to go ahead and present your paper? I'm sorry I didn't see you.
That's all right. I was just lost in the beautiful hall and love the conversation that's going on. Just before I start, I think one of the things that I've learned at this particular point is even before we start, and this is from our goose esophagus surgeons, is to put a rolled up cigarette butt like a gauze piece inside the chest even before you start every mammary. So if you have a problem like that and blood stained out there, you can just pick up your cigarette butt gauze piece, put it out there, clear it out, have a better look, and then buzz it with the bipolar. So I've seen many people taking down the IMA, but they don't do that. But it's a very, very simple thing. Half the time you don't even need it, but it's there. And then you can take it out at the end of surgery.
You hope it will stay on the heart, not fall behind the chest.
That's right. That's right.
You'll
That's
spend
right.
2 hours fishing it.
That's right. That's right. No, I put a long silk with it,
Yeah,
so
yeah,
you don't need a. It's
yeah.
I leave the hook. I leave the hook and sinker out, so you just pull it out then. Anyway, without much ado, thank you for the opportunity, and I will be talking about the grafting strategies that we have in robotic revascularization. Obviously, the need for this strategy comes from the fact that we're seeing sicker patients, we're seeing a whole variety of patients, there are a lot of comorbid factors, and we have patients who come in who are unstable with severe LV dysfunction. Sometimes they need a concomitant cardiac procedure. And if I were to post this slide and tell everybody what is the consensus on robotic-assisted revascularization, the answer is that there is no consensus. And that's the very reason why we can sit and talk about this. So we do know that the surgical options that we have in addressing revascularization is one of three things. We can either do totally endoscopic, TCAB, robotic-assisted mixed cabbage, or a hybrid. I must confess that I do not do TCABs, or haven't done yet, and I use a different platform from the SSi, so that option is out for me. So the two things that I can talk about are the hybrid and the robotic-assisted revascularization strategies. And coming to the hybrid, a lot of the time, I think probably 12, 14 years ago, the percentage of patients that we did robotic hybrid was around 10%. But over the years, that's come down dramatically. And I don't think I've done a hybrid for the past 3 or 4 years at all. And I think a lot of data across the world also echoes this sentiment. What started off with certain benefits of having a hybrid procedure did not get enough people to come in for the trial. That was the hybrid trial from the National Lung Heart Institute, and that trial also was scrapped. what is essentially a class 2A, class 2B. So there are centers that do hybrid, and there is a scope for it in certain population, but largely I think my experience on surgical revascularization strategies has been robotic-assisted mixed cabbages. And the data that I'm going to be basing my talk today is 14 years of clinical personal data reinforced with the outcomes that I've managed to see in these patients over 14 years. We've seen that a significant number of patients that we've been doing from traditional sternotomy to minimally invasive to robotic assisted has changed. There's an increase in the average number of grafts that we're doing. We're using more arterial grafts. There's significant reduced intraoperative time. So much so that my anesthetist, if I post a sternotomy case, when your anesthetist asks you, why aren't we doing this robotic? That means you're doing something right. So we've changed the way things are done, and we've been able to do more complex and even redo cabbages. So there was a certain scoring system that I kind of introduced around 11 years ago, and it was 3 levels of it: simpler, beginner, and the expert level. And over time, I find that this all can be scrapped. It's good in the learning curve, but if you ask me, does everyone get a robotic-assisted mixed cabbage? The answer is yes. Well, almost everybody. And the reason why is there are some patients that I would not offer this to, and this is isolated cabbages, and those are people who have significant aortic calcification. If I need to do proximals on them, that's relative. Ejection fraction lower than 25%, somebody who's unstable, diffusely diseased targets, and my current adage is that if they're not fit for a regular cabbage, they are not fit for a robotic-assisted cabbage. And just to share some of the data that I have based on the revascularization strategies, in 13 years of the data that we have, we've done close to around 2,300 mixed cabbages cases. Initially, there were a lot of single vessel disease, but today, triple vessel disease forms 80% of our patients. We've had 3 grafts of more than around 82 patients. And if you look at the data that we've had from 2012, you see that over the past couple of years, today we stand at almost 90 to 95% of all patients who come for a cabbage get a mixed cabbage or a robotic-assisted mixed cabbage. And that means here, you can look at the data in 2025, 93% of all patients who were referred for us for isolated cabbages ended up getting something like that. And if you see the role that the robotic systems have played, 2023 data, around 46% of my patients got a robotic cabbage assisted. That increased to 58, and last year I'm very happy to say that almost everybody got a robotic assisted cabbage. That's like 95% of them. The number of grafts that we've seen, in the initial years it was 1 or 2 grafts, but after in 2019, 2020, we've had an average of at least 3 or more grafts per case that we've done. And the use of bilateral IMAs, yes, it's pretty hard for the surgeon to take down a bilateral IMA with direct vision assisted, minimally invasive cabbage, but the robot changes everything. That 2022, that number went up, and now close to almost 55 to 60% of all our patients get bilateral IMAs. And that's the data out there. So how do I do it for the ones that I do not put bilateral IMAs? That's a small little video just sharing for everybody. And that's proximal clamp, put out there, mark out there. I know many of them love anaortic surgery, but for those of us who still use radial grafts or use venous grafts, I like to put them on the aorta. I'm not a big fan of sequences. I don't want to put all eggs in one basket. Although there are certain advantages, there are also certain disadvantages of having a lot of sequences. As you can see here, what the robot has taught us is for every case, we not only just take the IMAs down robotically, but also record the rest of the case with the robot. So what happens is we see in 3D what's going on, and enables us and the team to go back and look at all our anastomoses and see what can be done better. That's a smaller look at that. Here we've done 2, we've done up to 3 proximals, and that should not be a problem. And once that's done, we've gone on and see, and this is how the proximals look from the outside. Soft tissue retractors really help us get a better view of whatever is going on inside. And in real time, again, we see that we can do this. The time, I think, over a couple of years to do a sternotomy, CABG, skin to skin is the same as doing it robotic assisted skin to skin. It's the same time practically. Of course, there is a learning curve, and once you overcome that learning curve, I think the rest of it is pretty intuitive and straightforward. Yes, so that's the second proximal. We get that on and go ahead and do it. So whenever even we put a radial on, I don't like to put a vein patch, directly put it on. There have been times that I've taken down the Rima and put it directly onto the aorta, or sometimes just teed it off from the Lima, making a Lima radial, Lima Rima Y as well. So my preference, however, is to try and get the Rima directly onto the LAD and use the Lima inside too for the left-sided circumflex targets like the obtuse marginal. We've been doing a lot of total arterial, so I take a separate endoscopic radial and put it on the aorta and give it to a right-sided graft. So all three territories get arterial grafts and the problem solved out there. So anyway, I think Ritwik's doing this, but you see that little gauze piece that I was telling you about? That's a little thing that I put in out there, tied up right at the beginning of the case, so that if at any time there is any kind of bleeding, it's very natural for us to just put that gauze piece, push it out there, make sure that there is no bleeding out there and go on. There's a lot of debate on taking skeletonized versus non-skeletonized. I just think taking it with a small little pedicle, just a vein, artery vein, is so much faster, so much easier. I do not put any clips at this point of time, because anyway, I'm going to open a little sternotomy, so I just don't use a clip applicator 90% of the time. In case I do have a problem, then I do put a clip applicator. Of course, I do not underestimate the possibility of a bleed from these arterial branches, especially upper on and higher on. So once we make a small thoracotomy, I make sure under robotic guidance I use a regular long shafted clip applicator and put it on. It's much cheaper, it's much faster, and I can just isolate and clip the ones that I want. So like I said, so you do have both out there, and I think using the robot to take down the IMA, we can get an extra length of the IMA by just using a 30-degree scope. I've even tried doing it by the double docking both sides. It just takes a lot more time, and I think you can get really good length right from the top to the bifurcation just from one side. So using the robot, I have kind of, people have asked me, how do you get to the PDA? This is the 3D camera. Actually, this was recorded in 3 dimension, but I can't project it here, but it's just a simple way of doing the anatomy. We standardized every little step. I love the chase shunts. I saw that at Dr. Balki's place, and I've just adopted that. It's beautiful. And there is no compromise of the vision that you have, because whatever you're seeing naked eye, you can see it on your endoscope. The rest of the team can see it very, very clearly and see exactly what's going on. So this helped us kind of like standardize our approaches, and 3 grafts has become the norm, and we've just moved that on to all strategies. Doing endarterectomies is also an issue. Doing a Lima to LAD, of course, is very easy compared to the rest because it's right in front of you, but this is an obtuse marginal out there, and I've kind of moved away from using the starfish as well to stabilize, and I've just used the octopus over here, kind of the way that you do it in a TCAP, beating hard, just use the stabilizer itself to do everything. Once again, with the techniques out here, I think the time taken for the anastomosis is not really different. Maybe at the most 10 to 20% difference in a sternotomy versus robotic assisted CABG. Shunt out, de-air, measure your length, and of course I think the onus of the program lies in the results, and what we saw was a flow meter out there. So using a transit time flow meter, which is not very popular in our country, I think is the sine qua non. I mean, it's the essentiality for all the reasons put out there. And just to give you data of what we've done, last 12 months alone, if you look at 1,200 grafts that we assessed, we had a problem in 23, and that was close to around 1.7, 1.8%. And the good thing about the flow meter is even when you do robotic assisted, you can go back and fix your problem right then and there. And thanks to that, even if I were to do an open now, we have 100% compliance in using the TTFM data. I'm not going to show the TTFM video because I think most of us know how to use the TTFM, but these are instances that we've had problems and we went back and fixed those problems as well. So I think in our country and elsewhere as well, insurance purposes as well, it's a great record to have. It strengthens your robotic assisted program. And I think today, after doing this here in this country for close to 14 years now, 15th year going, almost everybody who comes to us gets a robotic mixed cabbage. These includes tight left mains, 90% left mains, beating heart, multi-vessels, endarterectomies, the works. If they're fit for a cabbage sternotomy, I would do it robotic assisted. We've been using a larger number of bilateral IMAs, and I think more data on that as we go on. But I think this is here to stay, and like we said, the more number of robots we have in the market, the less dominant one company is. And it's very nice to see how a lot of robotic companies or major robotic players in the world are once again focusing on cardiac surgeons, which was once a forgotten field for them, kind of step-son treatment, I would say, for many years, but I think it's come a full circle, and full credit to you as well for having this kind of a conference and conclave. Thank you.
Adil, with this robot-assisted CABGs, what are the concomitant procedures you can do with the robot-assisted?
So when it comes to a cabbage, I've been doing only for isolated cabbages. Like suppose you needed to do MVR and a robotic CABG, it's possible, but I've kept it very simple. I don't mix the two out there. I just leave it that way. There have been times that I've done a robotic cabbage to the right-sided graft and a mitral valve, but it's not my favorite operation. I would not do it that way. I think I would keep two separate. I would go for maybe a sternotomy or a minimally invasive surgery, a hemisternotomy if I needed to do both the concomitant cabbage plus another procedure. But for isolated procedures for cabbage, I think this is the way to go.
So harvest bilateral memories and through the fourth intercostal space to the minimal access we plan.
That is correct. That is correct.
And with that same left thoracotomy, you address all
of them, like you saw. And the reason why I didn't show the LAD, because everybody does the LAD, but the obtuse marginal, the right, the distal right, the PDA, everything that you do with sternotomy can be done.
That PD anastomosis, you happen to see the monitor and do it, or direct vision?
I started seeing the monitor as well. I did. Oh. Yes. No, it was direct vision though. But over the time, I started looking at the monitor.
Where is the camera placed? This is the.
It's the robotic. It's the left arm.
Okay.
It's the left arm. So space number 6.
And the opposite memory you harvest on the same side or
same side? Same side. So if I do bilateral IMAs, it's spaces 2, 4, 6. I use a 30-degree camera and flip it up and down when I have to go at the ends.
And if there is hemodynamic instability when you are doing it on a beating heart, how do you approach it?
A good anesthetist. It's as simple as that. Everything is doable.
No, but do you go on pump?
No. So I have data which actually shows, so out of those 2,300 cases, our incidence of using pump or pump assist is 0.34%. It's less than 1%. Our conversion rate for that is less than 1%. And we've got follow-up for 13 or 14 years.
Hemodynamic instability, when you are putting a right graft, how do you plan?
I think after the LAD, the right side is the easiest.
Okay. So you first do the LAD and then only approach the other side?
No. So the sequence of doing it is different. If I were to do a sternotomy, I'd first do a Lima LAD and then finish the right, then do the obtuse marginal, then do the proximals. Here I do exactly the reverse. I first do the proximals, Then I do the right, then I do all the left-sided, obtuse marginals or ramuses, and then the last I do the Lima LAD. And that I've learned from time is that if you do a Lima LAD and you lift it up for the right, especially in small-chested Indian women, you kind of disrupt your Lima LAD anastomosis some of the time. So that's why I switched to doing Lima LAD last. The exceptions to that rule is if I'm doing a tight left main, an 80% left main, no balloon pump, I do not do anything except taking down the IMA first and putting down on the Lima LAD. Only then I go ahead, dissect around the aorta, put in the thing. So basically convert a left main into not a left main.
While doing proximals, you use a retractor. Which one is that?
That was the original company was Vitalitech, and that's been bought over by different companies, and they're playing hockey with it. So I think right now it's with Peter Surgicals.
Great presentation, Adil. Congratulations.
Thank you,
so,
Dr. Bhakti.
2,300 robotic-assisted mix.
No, that's the total mix cabbage. The robotic-assisted mix are probably around 685 as of yesterday.
Yeah. And that's got to be one of the larger series of robotic mix. I know that Mark Ruel is doing a little bit.
Yes.
Keita is now starting to do some with the robot harvesting, but that has to be popularized because I think that there's no better way to harvest both IMAs than with the robot.
Absolutely, absolutely.
If you're going to do a T-cab, that's great. If you're going to do a mix cabbage, that's great. If you're going to do a sternotomy, that's also not bad. But harvesting the IMA is so precise and so exact with the robot that just do that and then decide how you want to
Absolutely, absolutely, absolutely right. I cannot echo that. It's great for the patient, great for you. Because taking that down, direct vision, even with the camera, it's terrible. Your back will hurt at the end of the case, and that's the reason why we never did it as often. But the past 4 years, we've seen that just jump up to 50 to 60% of all cases will first get the bilateral IMA, and then, like you said, then decide where do we put it.
And between you and Satyaki, it sounds like Bangalore has the largest.
It is the Mecca. It is the Mecca.
Yeah. So that needs to be published and popularized. And then my question to you is, what's the next step? What's next in your evolution of minimally invasive coronary bypass?
So obviously I'm here at this conference for that very reason. It's that little arm that helps me do the stabilization that we've spoken about when I visited your center, and you've been very kind enough to put me through that and let me learn. I think we need a very good stabilizer. And once we can get the stabilizer, at least some of us can emulate whatever you're doing out there and in Chicago. And I think that is the next step. And the very fact that, many of us are attending this particular conclave is because the SSi has a promise of getting us that particular system. And I think, I think that having a competitor in the field has also made the original system, kind of fast track and pay us more attention.
No question.
Pay us more attention. So I told the founders of the company as well. I said, finally, robotic cardiac surgery brings you to India, and so I think it's good for cardiac surgeons across the world.
Dr. Adil, a quick question.
Please.
I'm here. So, a great presentation.
Thank
Congratulations on your results. And I have two questions. You said that you don't use clip applicator while harvesting robotic assist.
That's correct.
How do you deal with the bleeding, the branches?
If you just saw the video, I didn't use any clip. It's all with bipolar.
Okay.
Everything is bipolar. So there are some branches that I will never clip, and you know that by intuitive, but all the branches above the second intercostal space have to be clipped.
Yeah.
It's very simple. You can pay an extra amount of money and use the clip applicator and take extra amount of time and clip all those things at the top, or you're going to make a small thoracotomy anyway. Just take that out and take a long shafted clip applicator and do it for practically free.
My second question would be, how do you deal with the hypertrophied and dilated dysfunctional hearts? without going on pump?
Yeah, so like I said, one of the don'ts that I do out there is do not do anybody who has an ejection fraction below 25. I'm very selective in people below 30% as well to go in for robotics. So I think one of the safest way of dealing with them is to not do them robotically. And the other ones that are there, I think it's all about positioning. I would make a little more space in the heart by maybe even increasing the incision by 1 centimeter to accommodate a huge dilated heart, even if the ejection fraction is good, and try and do it off pump. I'm a big proponent of off pump for what it believes and what advantage it gives. So I think it's very much doable. I think it just takes a little bit of learning how to do that and position that. And of course, as I told Dr. Hirmat as well, it's very important to have a good anesthetist and a good team at the backup. And I always tell my operating nurse, as soon as I scrub in for the case, she needs to switch on the sternal saw and let it rip so that I can hear that it's ready at the back table. So that's the last thing I want to do, but I want to know sure that it's there.
Thank you.
Thank you.
So incidence of conversion to a open sternotomy?
Less than 1%, 0.68.
Like what made you to convert?
So most of the time, it's been an arrhythmia. So sometimes I've finished the bypasses, I've given protamine, the patient has an arrhythmia and I can't shock him out of it. So by the time I thought deciding between a femoral cannulation going on pump to straight away doing sternotomy and putting on pump, I chose sternotomy. So that's a conversion. The second thing is arrhythmia, especially when you're doing young males with hypertrophied hearts. Sometimes an arrhythmia does not spontaneously resolve, and in those cases, I don't waste time to just go for femoral cannulation, but I straight away go on for a sternotomy. So, but the incidence is low. There's a scoring pattern that I've done and a scorecard that I use that tells me what level does this particular patient fall into, and that's helped us decide and strategize for that patient. So if I know that this patient is given, and I've learned over the years, like we've had another guy who did not have a tight left main, just 40%, but was highly arrhythmogenic, even while placing for an LAD. He was a guy that I electively put him on pump. Young guy, 45% ejection fraction, but he was highly arrhythmogenic. So I think arrhythmias are the bane of minimally invasive surgery, and for them I would not hesitate to convert.
And these cases, when arrhythmia sets in, not settling down with the defib shock and all, and how fast you can undock the robo and then do a midline sternotomy?
So I think when the robot is in place, the unshocking is not a problem. It's the biggest mistake that all of us do when we try to shock somebody out is we don't inflate the left lung. We forget that air does not conduct electricity. So either pour in a lot of saline into the left chest or ask the anesthetist to inflate the lung and do it. So I think it's less than a minute. So you inflate the lung up and shock him out of it. So that usually works.
And if you want to do a sternotomy, you need to undock or?
Yes, no, we have to undock. We have to get it out of the way. Absolutely.
And that should be done fast. It's possible within 3 minutes you are inside.
That's correct. That is correct. I think the team over time, the team is so used to it that docking and undocking is much easier. Anybody can do it fast. But like I said, always have the back table ready in case you do it. And my advice to people is, if you have a doubt about it, if you think somebody is not going to tolerate it, then at least do an empty beating heart. Or pump assisted if you want to, at least in the initial phases, and then get the hang of it. But I think eventually everything can be done beating heart.
And in pump assisted, you plan for a single venous canal IVC to same, or do you put another?
Just one. Just one. Even for the mitrals, just one.
Mitral one.
Also, just like for the mitrals, a huge good cannula right into the SVC, a little bit of vacuum assist. I'll take the little bit of hemolysis post pump.
For the ASDs too, as well SVC and everything.
That's correct. That's correct. I mean, with the kind of machines we have now, you can even do an ASD with a single line, so.
Okay. It doesn't trouble you while closing the ASD or airlock?
Yes. Yeah, no, airlock is, I think, out of the question now. I think Gravely's book of cardiopulmonary bypass needs to be edited. So airlocks are a thing of the past now with the kind of vacuum assist that we have and the kind of cannula we have. But yes, having a bloodless field out there when there is some, that's a challenge, but you can overcome that. But it's not a technical no. you can do that. I do remember one of my examiners, when I was taking the exam, told me, if you're doing an ASD, would you even consider doing it with just one cannula? And if I had said yes, I wouldn't have passed. So, yeah. Times are changing.
How about doing a Lima Y with robo-assisted?
I have not done that. I have not done that yet. But I think with due stabilizers, I don't see why not. It's possible.
Well, you people, you have been doing Lima Y with?
Yes.
And what is the stabilizer you use?
For TCAB Lima Rima Y, I generally will attach the Lima first and then bring the free segment, whether it's the distal third of the Lima or a Rima. Okay. So I have done Ys with the distal third of the Lima in order to preserve the Rima sometimes if I have a lot of length.
While doing the Y, how do you stabilize it? No.
Yeah, so I do the Y after the attachment, so it's already intact, and then I bring the stabilizer around the graft and stabilize it that way. So it takes away the movement of the heart underneath. It's not the easiest, and that's why we looked at recently over 1,000 TCABs with almost 2,000 anastomoses, and we found that the incidence of a Y graft in that series was literally 60 or 70 Y grafts. The far majority are in situ. Rima to the LAD, Lima to the back of the heart, or Lima to the LAD, Rima to the ramus. And very few Y grafts because it's just not that conducive.
You prefer giving a pedicle graft for the right and the left both?
Always, as much as possible, yeah. I like natural inflow, not man-made inflow.
Yeah. Adil, what about the use of radial arteries?
Yeah, we've almost, I think we have 60 to 70% of our patients get an endoscopic radial. Yes, very high.
That is endoscopic radial harvest?
That's correct.
And the proximal part, where do you fix it?
I'd love to put it in the aorta. Like I said, I'd like to have 3 separate ones, and
And that with the interposition vein graft or
No, I put it directly. One of the videos was actually the radial. The one that we saw, the first one was the radial. I skeletonized the radial and I put it directly on the aorta.
And what's the punch size you use when
you
use the radial?
Same size.
Same size.
Same size. Same size, same suture, 6-O-proline. Earlier, I used to try and do that with a vein patch, but I don't think it's needed. It just works really well without it.
And the post-op, how many times you happen to re-X these cases, if any time bleeding, and if at all you have to re-X, the approach will be same, or what do you plan?
I unfortunately had a re-X just day before yesterday. A celebrity from Mumbai who had come by, and I put the camera in. I first make sure I look at the X-ray before I take him in, and I told my anesthetist as soon as I saw the X-ray, it's a twig from the Lima. I done a Lima-Rima radial onto him, Rima in situ, Lima in situ. So I went back in through the same incision, spotted the bleeder, and put an extra clip on it. There was a clip on it, but it had kind of cut through, so that's there. So it's the same.
How does X-ray will help you when in a...
It'll tell you where the blood clot is. It's very easy. I wish I could show it to you now, but yeah. So there was a slightly larger hematoma near the takeoff of the Lima. So I knew right then and there that it's going to be from the Lima. But of course, once you're in, you look at everything else. But that's the first area that we went in, and we saw that, and we do it. But our overall re-exploration rate is 1.27%, almost 1.2 to 1.6% over the past 6 years.
And you were closing, you come up with bilateral ICDs and a mediastinal ICD, or only what's the...
So if it's Rima Lima, I use the Blakes, which we never used to get here, but we had in the United States. So I use a Blake, it's very flexible. I just use 2 Blakes, one on the right, one on the left.
And one pacing wire?
No. Both of them they go from the base to the apex, so they do the job of both. They're nice and long, and they rarely clot.
And routinely you put a pacing wire or no?
Yes. Yes. I still do. I'm a little conservative. I know a lot about all the Armstrong stories and the whole hoo-ha about pacing wires and the discussions in so many forums, but yes, I still do put a pacing wire.
Thank you very much.
Thank you, Dr. Saxena.
I think you have one more question.
Oh, sure, please.
Harvest the endoscopic radial.
Yes.
So, what is the sequence? You do the lima first, then do the endoscopic radial or something?
We do it at the same time.
Okay, so do at the same time.
At the same time.
It doesn't come in the way?
Nope. I actually had my physician assistant's really good, and he made a presentation about this at the physician assistant conference and a video about us how we set it up so you can do exactly the same time. So by the time I finish Rima Lima, he's harvested the radial and finished preparing it. So, same time. Okay, great. I think that is the end of it then. Thank you very much.
Thank you. Should we check in with Ritwik in the OR? Can you hear us?
Yeah.
Ah, good. How are you doing?
Yeah, it's a painful day, Dr. Balki. So anyway.
You're at the top of the IMA now?
Yes, yes, I am at the top. This is the top of the IMA. Yeah. There are a lot of adjacents and, it's very badly stuck to the chest wall for some reason.
Yeah.
So it's a day of advances to different places. The lower part is already done till the bifurcation. We have tackled the bleeding so far.
Yep. It's a little less stuck up here, it looks like.
Oh, sorry, say that again?
It's less stuck here in this area.
Yeah, no, this is okay, sir. This is fine.
Yeah. Is your plan to do mid-cab?
Yeah, so we have got 3 or 4 gaps, so I think then Dr. Srivastava will be not happy that if he doesn't see me in the evening. So I think let me call it a day. Is it okay, sir?
So you're going to take Lima and veins?
Yeah.
Is that a branch you would put a clip on?
Yeah, I will put a branch here. We are almost in the top, sir. Look at this, it's all done.
Yeah.
It's all done and it's all separated from the chest wall. There is some adhesions here, so just clip that and so I can show the entire memory now here, and it's just attached to this part. A lot of adhesions, and the chest wall is really looking quite bleedy at this stage, but this should be all right, I think.
Yeah. When you give heparin, it's going to be a little bit complicated, huh?
Yes, sir, I know that, yeah.
Are you going to suction out the pleural space before you make the incision or after?
After the incision, sir.
After the incision, yeah.
Yeah, yeah.
With the robotic magnification, it seems like there's more blood than there really is.
Yeah.
Yeah.
o'clock already.
Well, we have a panel discussion till 5. I think Dr. Sudhir might be getting back, so if you want to talk about any topics,
Who's on the panel?
you can press the people.
Is everybody here?
Yeah. So Dr. Walter will be leaving in 10 minutes. And then all
Quarter 20 करना please.
the person who's here.
Check it out, otherwise it's 4 o'clock already.
Yeah, multispecialty is not done yet. So, what would you like to do?
Well, I don't think we should wait half an hour, 15 to 20 minutes is fine.
Yeah, we have actually 1 more hour left, but maybe let's do it right now.
Huh?
Let's do 30 minutes.
People have to go back and come back at 5:30, whatever.
Okay, let me get permission then. And like some more people.
This is 20, no?
Sorry for the interruption, but I would like to request the rest of the faculty, if they can, to come join up front for our panel discussion. We're done with today's presentations, so we can have a productive discussion on any topic that you'd be like, especially today is the last session. So now would be the time. Please join up front towards the seats with the mics for the panel discussion.
So, Dr. Balki, I think I am done with this, and
You've got the whole length of it, it looks like all the way down to the bifurcation, huh?
yeah, yes, sir.
Cool. Well, congratulations on a very, very difficult harvesting.
Thank you,
sounds
sir.
like
Thank you.
you're
Thank you
gonna-
for all. Yeah. Thank you all for the kind attention. We'll get back in the evening, sir. Thank you.
Okay, great job.
Let's give a huge round of applause, please.
Thank you, sir. Thank you.
Good luck with the rest of it.
Thank you, sir. Thank you.
So, quick question to everyone in the audience. Would you like to adjourn or go forward with another discussion? I'll take a vote. Adjourn? Panel discussion? Anybody?
I don't think we have much of a panel left.
All right, I guess then we can conclude.
We've had lots of
Indeed.
good discussions, yeah, very good. Great, thank you very much, and thank you for our lovely hostess, Dr. Abi, who did a great job in keeping us on track and organizing the meeting, so good job.
Thank you so much, Dr. Balke. If you guys don't mind, we're going to do a very boring segment to conclude this up.
Well, ladies and gentlemen, we have reached the conclusion of the formal academic program of SMRSC 2026. And what an incredible journey it has been.
It has been great. 3 days, dozens of faculties, and one resounding message that robotic cardiac surgery in India has arrived and it is here to stay.
And none of this would have been possible without the extraordinary vision of Dr. Sudhir Srivastava and the entire team of SSi for building not just a world-class surgical program platform, but a community of surgeons committed to pushing the boundaries of what is possible for our patients. SMRSC is your gift to Indian cardiac surgery and beyond. Thank you so much, sir.
To every faculty member, moderator, chairperson, live surgery team, and delegates, you have made the summit truly special. We will carry these learnings, these connections, and these inspirations back with you. I'd also like to especially thank our AV team in the back. A big round of applause for them for this entire summit, the entire team of SSi, and all our ground staff as well.
Well, thank you so much, ladies and gentlemen, once again for joining us today. And this evening belongs to us. At 5:30 p.m., please join us for the enchanting Rajasthani cultural program, folk music by Mast Kalandar and the spectacular Khumar dance. And at 7 p.m., we celebrate together at the gala dinner.
I'd also like to request everyone in the summit room to please join the multi-specialty room. We'll be having a vote of thanks, and after that, we'll be moving forward to the third floor. Sorry, the plan has changed. The vote of thanks will be at the gala dinner itself, so I guess we'll see each other at dinner. Thank you so much, everybody. Again, a round of applause.
Thank you so much, and have a great evening ahead.